Chitrakala. So good evening, everybody. After a long, hard day's work, now let's get into a little bit of academics. So on behalf of Endocrinology Committee of Oxy, I would like to welcome one and all for the first webinar on endocrinology by the Endocrinology Committee of Oxy. So it is a real pleasure to welcome one and all for this meeting, for the focus meeting which we would be having one every month. So to start with, I would request our President, Dr. Jayarani Kamaraj Madam, to deliver the welcome address. So Madam does not need any introduction. Of course, she is the current President of Oxy and a very excellent organizer and a versatile speaker. She is a reproductive medicine specialist and also member of various organizations with many accolades to her credit. Madam, kindly deliver the welcome address.
Vanakkam, anevarukkum vanakkam. Thank you, Mala, for the nice introduction and a very special welcome to all the senior faculties, my dear friends, and all the teachers and all the Oxyans who have logged in. And a very special welcome to all the endocrinologists here, because this is a focus meeting on endocrinology. From Oxy, from this year onwards, we have started many committees. So in this committee, Malaraj is the committee chairperson. Along with her, the co-committee chairperson, there are 2 easy members. So with all this chair and the co-chair, they are doing a marvelous work. And to kickstart her endocrinology committee, Mala has made a wonderful program, which she has included the endocrinologist to focus on the adolescents. So we start our endocrinological problems right from the adolescents here. And I hope that every month she will be focusing on many stages of the women's life, which will be coming into limelight, which gives us a clear picture of how we go about tackling the practical aspects when we come across an endocrinological problem in the women's life. So I welcome you one and all on behalf of Oxy and my team 2023. I extend my warm welcome to the grand speakers here who are versatile in their specialty. Dr. Muthukumaran from the Endocrinology Society, Dr. Usharani Madam, Professor from Sri Ramachandra Medical College, Dr. Pushpalata from Ramachandra Medical College, and also my dear Vijayalakshmi Sheshadri Madam, and the moderators, Dr. Sindhya Madam, and all the chairpersons, senior chairpersons, Dr. Anjalakshmi Madam, Dr. Sindhya Madam, Dr. Dhanlakshmi Madam, and Dr. Shanti Gunasingh Madam, and Dr. Sai Lata for your presence here to share and to guide us in this webinar. And I have the great pleasure to welcome my easy members who are the panelists here, Dr. Vijayalakshmi Gnanasegaran, Dr. Mona Pramila, and the endocrinologist Dr. Anjali Satya, and Dr. Shanta Bhaskaran, all to form a great panel to discuss on a very important topic on the adolescents endocrinology. So we all have here all the doyens who can speak on this content in the best way, and that will be going to be a real academic feast for all the participants here. I can see more than 200 people have registered, and it's going to be the real good content oriented and very much focused webinar. It's a great appreciation to Mala for making this webinar a great one. And I welcome you one and all to this webinar, and on behalf of Oxy, I extend my warm welcome and regards to all the delegates too, and a very special thanks to Shield for giving us a nice platform and a good webinar to run the show. Thank you so much. I welcome you one and all. Over to Mala.
Thank you so much, Madam. So may I now request our very versatile Honorary Secretary, Dr. Kundavi Shankar, to say the Oxy Prayer, please.
Thanks, Mala. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of all your endless love. Thank you.
Thank you so much, Dr. Kundavi.
There's no video.
There is
No audio, ma'am.
Audio.
video also there. You're not able to see?
Ma'am, we can see the video, ma'am, but not the audio, ma'am. Can you please stop share and share once
Audio is
again,
not
ma'am?
there.
Oh, you're not able to see the video?
The song, no, we are not able
We
to
can
hear
see the
song.
video.
We
ma'am,
can
but
see the
audio-
video, we can't hear it. Mala, audio alone we cannot hear.
Okay.
Shall I share, ma'am?
So, Chitrakala, do you want? Yeah, Chitrakala?
Yes, ma'am.
Yeah,
I will
just,
share.
yeah, just share it. So, lighting of the lamp, are you sharing?
Yes, ma'am.
Yeah. Lighting of the lamp is symbolic of dispelling darkness of ignorance and lighting of light. Let's light the lamp and let the light of let light shine in everybody's life. Yeah, play it, Chitra. Chitrakala, just play the slide because now I have stopped sharing.
Sure, ma'am.
So endocrinology plays a very vital role in everybody's career. So one who understands endocrinology knows everything in gynecology and obstetrics, because once we understand endocrinology, we will be able to appreciate the treatment management in each gynecological disorder as well as in obstetrics. So having that in view, we have focused today on adolescent endocrinology. And to kickstart the meeting today, we have a very important topic, that is precautious puberty, when the child is too young, but then it is too soon for her to handle. To throw more light on this, we have our first speaker, Dr. Muthukumaran, and to chair this, we have our eminent chairperson, Dr. Anjalakshi Chandrasekhar Madam, who is the founder president of TNFOG, past president of Oxy, past president of DIPSI, and also she is her PhD in diabetology. She is a very sweet person as per her topic of interest, diabetology, and she has various awards like the best Doctor Award in IMA, and also she is a retired professor from Madras Medical College. So may I hand over the session to Anjalakshi Madam to chair the session on precocious puberty with Dr. Muthukumaran as a speaker.
Thank you, Mala, for that kind introduction. See, our interprofessional teamwork and the knowledge will help to serve our women folk. So in that, I congratulate the endocrine committee of Oxy for arranging this wonderful webinar on precautious, on adolescent endocrinology. And the first talk is, as Mala said, is on the precautious puberty. It is to be delivered by none other than Dr. Muthukumaran Jayapal, who is a renowned endocrinologist. Let us listen to him. And all of you, if you have any doubts, you can come forward or put it in the chat box and clear your doubts. Dr. Muthukumaran, please. To introduce, he is a managing director and consultant endocrinologist, ARCA Center for Hormonal Health Private Limited, Chennai. His postgraduate training in the United Kingdom and internationally accredited training in the internal medicine and endocrinology qualification. He is a research degree MD UK, University of Newcastle, and his special interests include insulin resistance, metabolic syndrome, patient education, genetics and prevention of diabetes, thyroid cancer, and genetic endocrine disorders. Honorary Treasurer of Endocrine Society of India, 2015 to 2018. Vice President, Endocrine Society of Tamil Nadu and Puducherry, 2015 to 18. Honorary Secretary, Endocrine Society of Tamil Nadu and Puducherry. Dr. Muthukumaran, please.
Thank you, ma'am. Thank you for the warm introduction. It's a nice evening. Thank you, Dr. Mala Raj, and everyone in the team, especially Dr. Jairani as well, for the warm invite. It's always a pleasure to talk about endocrinology, but talking about precocious puberty gives a little bit of jitters to everyone because we are dealing with young children. But fairly most of the time, these conditions are really straightforward once the diagnosis is made. The management part of it is very simple. We can go ahead, provided the diagnosis is clear. Next slide, please. So my objectives for this evening is to give you a broad outline of normal physiology, progression, and timing of pubertal development. I'll be a little bit brief due to time in this part. How to elicit a pertinent history with regards to precocity and the appropriate diagnostic tests and to how to interpret them as well. And there are some guidelines to manage these patients and how we can incorporate this in day-to-day care. Next. So we are all aware what puberty is, but by definition, it's a human developmental process that leads to sexual maturation and reproductive capability. For one to achieve this reproductive capability, you have to have intact hypothalamic, pituitary, and gonadal axis. What we mean by that, the communication from your hypothalamus to the pituitary and your gonads have to be intact and functioning so that the reproductive tract is capable of the process. It's highly influenced mostly by genetics and hormonal and nutritional factors. Next. So we would call these processes as adrenac, mostly around the 6 to 8 years of age, and which starts with the increased DHEAS goes up, followed by the growth of axillary and pubic hair. This is the initial process of puberty, followed by the gonadal maturation, which leads to the HPG axis activation, which causes further secondary sexual maturation. Next. So initially, the primary part of where the endocrinology bit starts here is we have pulsatile patterns of FSH and LH. These generally in little kids around 9 to 10 years start with during their sleep. So if they have good sleep, it starts during the night, and eventually they go on to have bigger pulses all throughout the day, leading to final maturation. People who do not have a proper sleep pattern or obese children, these pulses get deranged and problems with puberty happen as well. Next. So the major determinant of timing of puberty is genetics. You can easily question the mother at what age did she or her mother had started maturation factors. There is also suggestions that your geographical location, exposure to light, general health, and recently more critical is the body weight where maturation happens in most people. So you need to also achieve not only body weight, but also adequate fat reaches your body composition, which is primarily thought to be linked towards due to leptin. So you need, for sexual maturation to happen, you need an adequate body weight with some amount of fat, which can be linked to leptin as the primary regulator of puberty. Next slide, please. So in short, you start with the accelerated growth with pubertal development. You know the child starts growing faster, followed by telarche, which is the breast development, and then initiation of pubic hair, and followed by menarche. So this whole process takes around 3 to 4 to 5 years, which differs from different cultural and ethnic groups. Next. And this is some old slide, just for information for the general audience here. In the last 150 years, our age of menarche anywhere in the world has come down. And this is how dramatically it's come down. And even in the last 2 to 3 decades, we are going down further. So whether precocity will become normal in the near future is a question. Maybe in the next 50 to 100 years, we'll answer this. But certainly we are going towards an early puberty and menarche. Next. And generally, there is a population variation as well. African Americans start their puberty early and achieve menarche early as well, whereas Indian girls are slightly delayed. Caucasian women range between the two. Next. So how do you assess from the pubertal point from the history? Ask their onset of puberty in parents, what the menarche of the mother or the grandmother. Their parental heights also help us how this kid is going to end up. So genetic contribution to the height, whether the mother or uncles in the family was a late bloomer or an early bloomer, how they grew, did they take their time before they start puberty, when their height started going up. Those are all clues to find out when the growth is going to happen. And basically, you might have to chart these children on a growth chart, which will give us a more reliable idea where things are moving with marking out the mid-parental heights. Body changes, telarche, adenarche, as we have discussed. Body odor is an important thing where mothers are really quick in identifying. So most of the kids where mothers have brought their children to us identify body odor as the early marker of pubertal start. So body odor, when it happens in a little child, it's a warning sign that something is happening or something is starting to happen, followed by menarche and gonadarche. Next. So on physical examination, what we will do is height, weight. If there is a relevant diagnosis, then an upper to lower segment ratios. We would certainly document Tanner staging with axillary pubic hair staging, breast development, and genital development. A full examination is a need of the hour for these children. So maybe you might not do it on the first visit. I just do an examination on the first visit. The second visit, I keep it. Second or the third visit, you go for a genital examination, especially in little children. If necessary, we will also do a full neurological examination in these children. Next. So this is how most of you would go by Tanner staging. I'm not going to explain this, but we look at the breast growth, pubic hair, and the genitals as well. Next. What is precocious puberty? Precocious puberty is appearance of secondary sexual characters at any age, but it has to happen before the normal population where it gets, which is about 2.5 standard deviation below the mean age. So in clinical definition, appearance of secondary sexual characters, onset of changes prior to age of 8 years in girls and 9 years in boys. But the definition for African Americans is less than 6 years. So this is the definition of precocious puberty. Generally, when precocious puberty, we assume only girls get precocious puberty. There is a lot of male children also do have precocious puberty, but the average is again like your autoimmune thyroid disease. Every 5 child, there is a 1 male kid who undergoes precocious puberty. So it's slightly less common in male, but can happen as well. So what are the causes of central precocious puberty? It's idiopathic true precocious puberty where we can't find out a cause. For all this, we have to exclude all these causes, which I've listed down below, which is any tumors in the brain, any hypothalamic hematomas, which are very common in central precocious puberty, any infections, any trauma to the brain, any irradiation in the past can also start your central precocious puberty. Chronic exposure to sex steroids like immunosuppressant dosages, transplant individuals can also run into issues. Next. So there is, we talk about mostly central precocious puberty with precocious puberty, but there is also other conditions which kind of aggravate our precocious puberty, which is generally peripheral precocious puberty, which can happen due to ovarian cysts, estrogen secreting ovarian or adrenal neoplasms can cause it. McCune-Albright's is a rare syndrome, but can happen. We diagnose about 2 to 3 kids with McCune-Albright's every year. Untreated, prolonged hypothyroidism can cause peripheral precocious puberty secondary to your polycysts occurring due to this. And exogenous medications sometimes aggravated. The contrasexual precocity can happen in CAH and rarer types of CAH and virilizing neoplasms. Next. So next slide, please. When I say true precocity or peripheral precocity, most of these true precocity happens due to gonadotropin-induced, gonadotropin-dependent pathways, where there is activation of the hypothalamo-pituitary axis. This is central and this is always isosexual. So whatever sex the person has, it is hyperregulated and there is precocity. Whereas peripheral can be either isosexual or contrasexual, and the source of sex hormone is the gonad or elsewhere. Whereas in true precocious puberty, it's always gonadotropin mediated and it's always gonadal mediated, powered by your pituitary gland. Next slide, please. Next. Next. So how do we evaluate? I've got a few cases which I'll go through in the last 5 minutes of it, but history is important. Just make sure that the patient is not suffering from any other illnesses, any chronic history of headaches, growth disturbances, or CNS illnesses have to be taken into account. Clues for examination: testicular volume, a good genital examination, hair growth as well. And the rarer things are the ash leaf spots, the caphylase spots, which are indicators of things like McCune-Albright. Bony deformities are also part of McCune-Albright's, where fibrodysplasia is very, very common. Untreated hypothyroidism can also be a common cause for precocity. Next. So we bank on 2 or 3 things as an endocrinologist to diagnose our children. Most of these kids, we will, once the examination is done, we'll put them on a growth chart for sure. We will monitor growth every 3 monthly. The second test which we will do is a bone age estimation by an X-ray of their left wrist. So this is mandatory, and this is your starting point of examination as well, examination or treatment. So we measure bone age in serious individuals, measure them or do a repeat X-ray every 6 monthly or even a year to tailor the treatment accordingly. So sometimes on an average, we take once a year X-rays on most of these children. Gonadal steroids, we measure them. We also measure gonadotrophins to differentiate. But the last but the final test is we do a GnRH stimulation test. Obviously, when we do all this, we presume that the child is normal with a normal blood count, a liver function, kidney function, a thyroid function, and a beta HCG. Next slide, please. So this is the most important test, what we differentiate whether the patient has got precocity or not, and whether the patient has got central or peripheral precocity. So what we give a short-acting leupride injection at fasting, or it can be actually done any time of the day. Take a basal sample of a LH FSH. We give an injection of 100 mics and then do an LH and FSH response. And in central precocity, we expect the LH to peak around 5 to 8 or 3 to 4-fold from the basal thing. So all the LH assays which we do today are very, very sensitive. Generally, in central precocity, there is a talk that you don't really need to stimulate if you're very sure. But there can be cases where I've got a case to show that there is peripheral precocity where the diagnosis completely changes. So if there is any doubt, then always do a GnRH stimulation test to confirm this. Next slide, please. So if you get a good, if the patient is pre-pubertal and not entering precocity, they will have a FSH peak, not an LH peak. The FSH will go up more than the LH. And the pubertal response would be an LH greater than 10 to 15 or a 3 to 4-fold rise. And some people measure the ratios between the LH and FSH peak ratio should be not 0.66. But a peak LH of greater than 10 to 15 tells us that the patient has got central precocity. Next slide, please. But there is a little bit of considerable overlap between these things. So other indicators, growth factors, the height response have to be taken into account. Next. So role of imaging, part of examination, primary examination and ultrasound abdomen is always a necessity. In gonadotropin independent peripheral precocity, most of these individuals will go on to need either a CT or an MRI to exclude adrenal or gonadal tumors. In central precocity, most of these kids will have an MRI just to make sure that they are not having a tumor in the brain or any other CNS pathology. So what is the change in sexual orientation here? 40 to 90% in boys will have a CNS pathology, whereas only 30% of girls will have a CNS pathology for precocity. So more boys will turn out to have problems for their central precocity, whereas there is a significant proportion of girls who go into precocity without any problems. But when when the age is greater than 6 years, only 2% develop problems. So if the girl's age is less than 6, they may have a common issue any problem which we have already discussed, but anything greater than 6, then the possibility of a pathology being there is less. Next. So this is the graph which tells us the lower the age, you might have a problem somewhere which is causing the precocity. The older the age group, the problem might be less, and male kids may have always a problem leading to precocity. So the idiopathicity of your central precocious puberty is lower. Next slide, please. So objectives of management is about arrest premature sexual maturation of these kids. We don't want kids to have starting their periods and losing their childhood. We want them to achieve normal mature height. The problem with precocity is all these kids are taller at their 4th or the 5th class, but they end up being the shortest when they reach age of 12 or 14. So there is early onset of puberty, but their velocity of growth is shorter for a shorter period. So their growth period is minimized, leading to short stature in the future. So they lose a lot of growth velocity for a period of a year or so, leading to short stature. So this is a big problem from precocity as well. And detection or untreated, undiagnosed tumors, which can also lead to precocity. So always image these patients more carefully than anybody else. Next. So the later part is preventing emotional disorders due to early menstruation or other problems. There can be also self-care issues in very little children who start their periods around the 7 or 8 years old. Prevention of pregnancy is also a concern, and sexual abuses are being noticed. and maybe a possible reduction due to associated with early menarche is also one of the reasons thought to be. Next. Who should be treated? Anybody who has got a bone age of greater than 2 years, who have decreased predicted height, significant anxiety due to menstrual age, and individualize. We have to treat the patient as an individual. Next. So options for central precocious puberty, GnRH analog. There is no worries at all. We have had children going on GnRH analog for 10 years. We have started, the earliest is about 2-year-old kid going on to have until 12 years, no issues. Rarely anti-androgens and progesterone has been used, but GnRH analogs are the standard of care. Next. We use always Lupride as the thing because we use it more often. Other things can be used as long as you're comfortable with it. As long as the GnRH axis is suppressed, we are happy and the success rates are good. Next slide, please. I'm going to rush through 3 or 4 cases in few minutes. This is the first case, 21, the 2.5-year-old girl brought by her mother for breast development, which she noticed 6 months ago. She had a sweat odor, growth spurt was happening, and she did not have any axillary or pubic hair. Next. Her height centile was over the 90th centile. She was from a village. We were a bit concerned about that. No CNS defects or capillate spots. The bone age at 2.5 showed 6 years, 4 years on top of it. Next. And this is what her baseline blood showing the LH to be higher. Next. And the GnRH stimulation was typically positive for central precocity. The USG was still showing a prepubertal uterus. So this confirms precocity. Next. Her MRI brain was normal. We started on analog therapy and we maintained her for quite a while until she achieved puberty at the normal age of 12 years. Next slide, please. This is a 9.5-year-old girl. She was brought to us with worries about short stature. She attained a menarche 4 months ago. We were concerned, obviously, the parents brought the child a little bit late. The question was whether to investigate her at all. Next. Her breast development was noticed on questioning at 7.5 years old. Growth spurt noticed at that time. No medical intervention was done. She had almost full puberty. Her bone age was very much advanced at 13 to 14 years. And she has attained her menarche according to hormonal status, and the uterus was post-pubertal. Next slide, please. This is again precocious puberty without treatment or late treatment. She has had central precocity as well. Next. Should we investigate? It's very difficult. We get a lot of cases like this. The challenge is how mature is the child? How is the societal concerns? We generally, if we think the precocity is due to an organic problem, we at least do an MRI. Next. But there are some cases where we have used growth hormone with GnRH therapy together. So if at all there is a kid who is concerned by short stature, very early puberty, then there is some evidence to suggest growth hormone along with GnRH therapy may help in these children to improve their heights. Next. A 5-year-old child was brought to us with breast development 6 to 8 months prior. She did not have any axillary hair or pubic hair, no vaginal bleeding, no sweat. Next. She had A1, P1, and a B3, just breast growth, chronological age and bone age were matching. Her GnRH test did not show any pubertal response. Her USG showed a minor ovarian cyst, which was unremarkable. Next slide, please. This is called isolated premature thelar, which is just breast maturation in children. Generally, they regress after a couple of hours, they stay put, and we don't worry normally about it. We do want to keep these kids on observation, but generally, these kids are more reassured than anything. We do a GnRH stimulation test, keep them on monitoring their height and bone age. Next slide, please. Reassurance and close follow-up is the need of the hour. Next. And the last case is a 7-year-old girl brought by her mother for breast development again. There was no growth spurt, but sweat odor was there. There's no axillary and pubic hair. This is slightly a different case from the first case I showed you, because here there is no growth spurt at all. Next slide, please. The height was lower, less than 50th centile. No CNS defects, no capillate spots. The bone age was advanced at 9 years. Blood investigations. Next. Here, these are the basal bloods which were normal, but the estradiol was very high at 184. The GnRH stimulation test showed that there was a poor LH response, but for a raised FSH response. And this is gonadotropin independent precocity. So the catch here is this girl has got high estrogen, no advanced bone age. There is something fishy or abnormal here which you're missing. She's currently under evaluation. We suspect that she may have McCune-Albright syndrome, and part of the precocity is due to that, although she has not got any capillate spots yet. Next slide, please. Letrozole may be an option of treatment, but we want to image these kids as well for with an MRI just to check for adrenal and gonadal tumors. Next slide, please. So the areas of uncertainty in precocity are which age should we start treatment, which age should we stop treatment, whether we should differentiate between progressive pathological origins of precocity or non-progressive patterns of precocity. When to stop treatment is a very, very difficult thing, even for us, but we tend to stop around the 12 to 13 mark. Additional treatment to achieve the final height is also, certain cases it might be necessary. The other thing is, if you do find a lesion, if wherever possible, the CNS lesion should be primarily treated first. Next slide, please. So always measure, the 5-step approach for these kids are always measure a bone age.
Chitrakala, what happened?
Thank you, Dr. Muthukumaran.
One second.
My final slide.
Yeah, not at all.
Dr. Muthukumaran, thank you very much. You have taken us from the physiology to the very clinical, different clinical scenarios. So very nicely done. Thank you.
Yeah, Anjalakshmi madam, just I think one more slide is left, ma'am.
Yeah.
Oh, okay.
So I'll finish up, ma'am. So the banking factors are bone age, ultrasound, or the GnRH stimulation will help, and look at the adult height. Finally, early puberty is not a very, final slide, please. Early puberty is not an uncommon condition. Our clinical examination should be focused on the growth rate, relevant hormonal investigation, looking at the child's age as well as the stature is important. Their sexual maturation correlating with it is important. Gonadotropin analogs are very, very safe, so don't worry about them too much. There are still some gray areas, detailed counseling and close clinical observation may be necessary. Thank you so much for the time and listening, ma'am.
Thank you, Dr. Muthukumaran.
Thank you, ma'am.
Are there any questions? Mala, any questions in the chat box?
Yeah.
Good evening, Dr. Muthukumaran. Can I ask a couple of questions if there's time?
Sure, ma'am. Yes, ma'am. Certainly.
I'm Dr. Shanta Bhaskar. I'm working in Apollo. Earlier, I was in railways. So your second case, I was just wondering, because of the short stature and all that, I mean, this is just a doubt I have in my mind as to whether it could be a Turner mosaic or something like that, and therefore the short stature. And and of course we should also be looking for Turner stigmata, and whether it calls for any chromosome analysis. I mean, that is just a doubt I had when I heard that.
This is, yeah. So whenever we assume precocity, we always assume that their LH FSH is always normal. So if the FSH, we make sure we do this in everybody. If there is a doubt, we also do a karyotyping. So the basis has to be normal before we move on. So because of time, I've not put all the details, but basically the girl basically is, we have to exclude Turners before we move on to this level.
Turner mosaic, because obviously Turner will not have precocious puberty. Then in case 4, you were saying that she had she had increased estrogen levels, and you didn't know where it was coming from. You didn't know the source. Whether it could have been dietary, because now we do have dietary increased rows of soy and the cow's milk being the cows are fed all kinds of things, and I mean
the like premature talaq, you mean, ma'am?
Your case 4, I think you said no, that was not premature talaq. Okay. The last case,
case of
precocious puberty, case 4.
Yeah. the gonadotropin independent precocity.
Yeah,
so
yeah,
this
yeah.
is
You said, yeah, exactly. You said that GNRH test was negative. So,
Yeah.
but then you said, you mentioned that you didn't know where the estrogen is
See,
coming from.
Yeah, that was the catch here. The thing is, this girl had a low LH. The estradiol was very, very high. But the maturation factor, yeah, the estradiol was the only marker, but the LH and FSH were normal. So that is where our thing is, like, the height is not. So the exception is she's not going through the normal pathway of the gonadotropin dependent precocity. Yeah. So we need to look into that. And that's exactly why there is argument in literature suggesting that we shouldn't do any gonadotropin stimulation tests at all. But this is one case where you will miss it. If you're not doing it, at least the diagnosis will be delayed when you do not stimulate the patient. So that's exactly to differentiate both the conditions. I've put this case.
Yeah, thank you.
So there is a question in the chat box.
Yes, ma'am.
There is someone who has asked, in second case, how we diagnose CPP? Why can't it be physiological? Because she has normal values of FSH and LH. Yeah, second case.
See, it's the age always. The precocity is somebody who is achieving their puberty earlier. If you look at it, the history started around the 6.5 years mark. The parents didn't seek medical help, so that what we're trying to focus is the diagnosis has been missed here. So you cannot have physiological pubertal start. If it is at 6.5 years, it's not physiological. That's all. It is precocity. You have to have at least 8.5 commonly in an Indian setting to have starting features of 8, 9 is a common thing where people start maturing or starting to mature. So that is why we call it precocity, ma'am.
So only before 8 years, you call it as precautious, right?
Yeah, technically, yes.
Technically, yeah.
And
okay.
Dr. Muthukumaran,
yes,
is that growth hormone, is it necessary when we have that central precautious puberty and starting on LHRH?
It is certainly not necessary when we start GnRH analogs early, ma'am. So if you're starting a child before the age of 8 or 7, you do not need anything. These kids will grow normally. There will be adequate suppression of the GnRH. So you go through normal pubertal process, and when you want to release the kid, you just release it. Whether a lot of the times the patient can't afford it, taking it too long. So we try to keep that short wherever possible, but we release them around the 12 years mark so that they achieve the maximum height wherever possible.
But because we say before 8 years precautious puberty, so why not we stop the treatment at the age of 8 years?
See, most of these kids would have lost a couple of years of height. Okay. So the height is one of the major concerns where we get patients with.
Yes.
We have children to us at the age of 15 and 16 asking for 2 centimeters and 3 centimeters growth. The parents are so hooked up to it. So to maximize what they have lost, we are doing this. And the exact case that we have given is a realistic case. We come across at least 4 to 5 times a year. People from all over the country coming to us and saying, can you not manipulate this? Can you not give us extra 3 to 4 centimeters growth? Okay. And that's where the scenario happens. So they come at the last minute. They have achieved puberty already. They are in the final stages of puberty or menarche before they move to adulthood. And at that time, you can basically, by just giving them GnRH, you're just blocking that pathway. There are papers suggesting that if you give them growth hormone plus GnRH, there is a minimalistic gain, like around 4 to 6 centimeters over a 2-year period. So whatever you gain for your efforts are tiny, but people are after it.
Thank you.
So how do you take care of the bone loss when you put them on GnRH?
We make sure that we are giving them adequate calcium and vitamin D. Generally, we make sure all these kids are on some kind of vitamin D. I give them at least 2 courses a year and make sure that the kid takes a good amount of milk and curd to keep up their calcium intake. If they're not keeping up with them or they're intolerant to lactose, then we give them calcium as well, ma'am. But a good amount of vitamin D in the children should be more than sufficient. And generally, the early part is safe. Only when we are blocking after post-pubertal, the problem happens, and the bone density happens until the age of 28. So even there is another 14 years. The other part, what you can advise them is to keep them active so that they are not losing their bones. So activity, a good vitamin D level, and some good calcium intake should not be an issue.
So what would be the dosage of calcium and vitamin D in these young girls?
Whatever vitamin D we give seems to be insufficient in all our children. So I stick, if at all I could give them 2000 IU, I give them, or like a maintenance dose. So you always start with the 60,000 for 8 weeks and then start with the maintenance dose, which is either a 2000 IU every day or a 6000 IU once a month.
Right.
So that should be sufficient, ma'am.
Thank you so much. So this body odor concept is a very nice thing. I think something which we came to understand that, that is a early sign for us to identify that the child can get into precautious puberty.
Yes, ma'am. That is one of the things the mothers are really concerned with. And some of them just ignore, some rarely. We are all running busy lives these days. So that's one of the main reasons. But the body odor is one thing which grandmothers and mothers pick up.
So that's a very nice, valid point, sir. Madam?
Thank you, Ma. We can.
Yeah.
Thank you, Dr. Muthukumaran. I thank the Oxy for this opportunity. Thank you.
Thank you so much, ma'am.
Thank you so much, Anjalakshi madam, for chairing this session. And thank you so much, Muthukumaran sir. Very, very informative session. Thanks a lot.
Thank you, ma'am.
So we move on to the next topic.
I have a great privilege in introducing Dr. Mala Raj. Mala Raj madam is a well-known lab surgeon, and she has got a passion for lab surgery, and she has got a lot of fans in around the country. She is the founder secretary IAG Tamil Nadu chapter, managing council member IAG, joint treasurer Oxy, past secretary of IMS Chennai chapter. She has a training in advanced laparoscopic surgery in Strasbourg, France, and China Medical University, Taiwan. Foxy and ICOG recognized. She has got a Foxy and ICOG recognized training center for endoscopy. She has trained in aesthetic. She is trained in aesthetic gynecology under Dr. Red Alinsod, California, accredited menopause practitioner.
Thank you, Dr. Mohan. I think we'll move on to the speaker.
Every time this one thing I have to tell is Dr. Mala Raj ma'am, after her session in lab training, common doubt every delegate used to ask is how she is maintaining her fitness. So she has got fans for lab surgery as well as for fitness. Welcome, Mala Raj ma'am.
Okay. Thank you so much, Dr. Mohana. So now we move on to another very interesting topic, primary amenorrhea. So just like the previous one, how too early is an anxiety for the parents and for the child. Again, too late is also an anxiety for the parents and the child as well. So when the girl is not attaining puberty, even by 16 years with all the developmental secondary sexual characteristic, we are always concerned and then worried as to how to to overcome this. And as gynecologists also, there are many things that we have to keep in mind. So to throw more light on this, we have our next eminent speaker, Dr. Pushpalata Barua madam. Madam is a professor in obstetrics and gynae in Sri Ramachandra Medical College. Madam is an UG and the PG teacher for more than 30 years. In fact, madam she was also my teacher, and her special interest is mainly this current topic, that is the gynec endocrinology, high risk pregnancy, and also in recurrent pregnancy loss. So let's hear from madam how to manage a girl with primary amenorrhea. Over to you, madam.
Thank you. Am I audible?
Yes, ma'am.
Can
share madam's?
Yeah. Yeah, I think I'm.
Yeah.
First one. Yeah. Thank you, Mala.
the pendulum has swung like from precautious puberty to delayed menarche. So absence of, I would like to deal with the evaluation of primary amenorrhea. That is, amenorrhea is just a symptom wherein you find that the patient has not attained menarche. Okay, so I'm going to deal with evaluation of primary amenorrhea. And the second one is a management at a glance, because it's a very detailed topic. So absence of menses in a girl who is 13 years old with no secondary sexual characteristics. How we have come as 13 years is, like doctor was also telling, it is more than 2.5 standard deviation. Okay. So if she has not attained by 13 years and she has no secondary sexual characteristics, we have to evaluate this girl. If there is absence of menses in a girl who has secondary sexual characteristics, but she's 15 years old, still we go ahead and evaluate her. And in special situations, any age, like a mother brings her because she's the shortest girl in the class, or she has cyclical abdominal pain. She's only about 10 years or 11 years. She has problems, or she's got a newborn child has got a mucosal. So that way you have to investigate. Otherwise, we investigate in these two ages. As usual, in any problem, we have to go to the history. This is not a very exhaustive history, but just that, we have to prove that it's a chronological age. I mean, age is correct. There's when did she have onset of breast development, axillary and pubic hair, and whether she has any history of cyclical abdominal pain, headache, visual disturbances. Is there any absence of smell? Sometimes there's absence of smell, only the person who's with the patient will tell. The patient herself may not realize. And did she have any illness, which is a prolonged illness when she was a child? Did she have any surgery, any childhood malignancy for the radiotherapy, chemotherapy? So the history taking has to be a very, very elaborate one, including many points which are not given here, but just to give a glance. Examination, of course, examining a 13-year-old, how difficult it is, but just try to do a general physical examination. Always check her blood pressure, breast, axillary and pubic hair, Tanner staging. I think we would be able to do arm span. You can measure, you can see whether there's any abdominal mass. And as doctor was telling, sometimes it's difficult to examine the external genitalia in the first go. And after you gain her confidence, you can. Otherwise, if they're willing, we can go see the external genitalia. Is there any clitoromegaly? Are there any hernial orifices with any hymenal opening is there? Sometimes you may not be able to assess the vaginal length immediately. You have to wait for some time. And nowadays, I don't think we are really doing per rectal examination. Previously, we used to, but now we are trying to avoid because more of discomfort and may not get much of information. I would always like evaluation of primary amenorrhea in something. There are lots of classifications, but I feel this compartmental classification is what I use day to day, and I find it very, very informative. So compartment 1, and this is for the postgraduates also. Compartment 1 is the uterus, okay, and the tract. 2 is the ovary. 3 is, it's easier, the pituitary, and 4 is the hypothalamus. So if we can find out, in which compartment our particular patient has got a problem, then we can go into the depth of it, because each case will vary. So, and I have tried to integrate this compartment classification as well as the next classification. This compartment classification, I've just given examples of like compartment 1, when we say it is outflow tract, we say it could be an imperforate hymen, or it could be a transverse vaginal septum, or it could be that the uterus is absent. Compartment 2 focuses on the ovary, and it could be a Turner or a gonadal dysgenesis or any ovarian failure or any gonadal failure. It could be even an XY gonad which is failing. Compartment 3 is mostly the pituitary, wherein our imaging also helps. There is like Sheehan's is not, it is because some people used to say that for primary amenorrhea and secondary amenorrhea is same. So this has been included, but I generally like primary amenorrhea to be treated separately, because Sheehan's, like one of the things which comes post-delivery doesn't ever occur in a primary adolescent. And empty sella can occur, but not she hands. And compartment 4 is hypothalamus, of course. So we have this, if this compartment classification, if you can really understand and see how your child fits into it, it is a really good one. The second, another classification, which is based on secondary sexual characteristics. This is also good because in a way, when a child walks into your clinic, you will have an idea. If she has got normal secondary sexual characteristics, then you know that she's got estrogen in her body. And she has no secondary sexual characteristics, then you know that there is no absence of estrogen. The third one, which I'm really not going to discuss in detail, is heterosexual. Like probably she was reared as a girl, and then suddenly she starts virilizing, okay, has more of hair, and clitoris starts developing. This is also a big concern for the parents, for the child, everything, but I'm not really going into detail. So I'm going to discuss only these two. This is normal and the absent secondary sexual characteristics, and I will try to integrate both. So if a kid has, she has got normal secondary sexual characteristics, then generally the next step, which you can, this thing is, do a USG pelvis, we say, but I would prefer a abdomen and pelvis as an ultrasound. This is easily available, and we can get an information. Then in this, we have two things. The uterus is absent or uterus is present. So then we go to the next, go to the next one. If uterus is absent, then we go for this karyotyping. So you have a girl who has normal secondary sexual characteristics, and uterus is absent. So then we go for karyotyping. You find out if she is 46 XX or she's got 46. Generally, there's only two conditions in this. Maybe sir might have more, but in general, normal practice of this, we see only two. And 46 XX, this, we say that the uterus is totally absent, and vagina is also absent. Then you've got Mayer-Rokitansky, Kushner-Hauser syndrome. It's a very thing. It's quite a common disorder. Next to Turner's, we see that MRKH is the syndrome which is there, but it can be partial also. Okay, but complete, then we call it as Mayer, but it can be partial, like some amount of rudimentary things can be present. Okay, so, and this is associated with renal and skeletal anomalies. So we have to look out for renal and skeletal anomalies. The next one is, if it is a 46XY, that is normal secondary sexual characteristics, good breast, little bit of axillary and pubic hair or may not be there, but looks feminine, okay, good height, then it could be a complete androgen insensitivity. So in this, it's an X-linked disorder, okay, recessive. And what happens is, because the gonad is working well, but it is not able to, the receptors are not working. So the testosterone is in normal level. It is not able to act. So whatever little estrogen is there, it is acting on the breast and producing it. Because that gonad is working, it is also producing anti-Mullerian hormone. So since it's producing anti-Mullerian, uterus is absent. So this will be sex of rearing will be a female, external genitalia, because testosterone is not able to get converted to DHT and act on it. It is like a complete female. But the vagina is very, very short, blind vagina, almost just a dimple or a little bit of vagina is there, 1 to 2 centimeters. And all, whether this any gonad has to be removed when it contains XY and it's in an abnormal condition. These girls will sometimes have intra-abdominal, this is like gonad I'm telling, say XY testis, intra-abdominal and more chances of malignancy. So gonadectomy is advised, but because it is better to do it after she attains puberty, because she will have good height. These are the two conditions. So normal secondary sexual characteristics, if they have, do an ultrasound, then uterus is absent, do a karyotyping. This is how we take it forward. And also you can develop a good vagina. So vaginoplasty is common for both because they do not. Then if uterus is present, normal secondary sexual characteristics, ultrasound comes, uterus is present. So probably could be an outflow obstruction. The problem is here, outflow obstruction can be starting with the level of cervix, it could be upper vagina, septum, or it could be finally the hymen. So if hymen is there, it's easy. You can see the bulge, okay, and you can do a correction there, and generally we have a good outcome. But if there is a septum in a higher level, it has to be MRI is preferable to do and see proper this thing before you do a septal resection, because you should not cause more damage like to the urethra, bladder, and the rectum. Because some of them are very tight. You have to do you need guidance to do all these septal resections. And then comes the cervical stenosis. Sometimes cervical stenosis with the functioning uterus can create a lot of problem. It can cause hematometra. And here also, there are mostly, previously we used to advise hysterectomy, but there are reports coming saying that you can create a cervix very rarely, keeping in mind that it can lead to sepsis and pyometra and all that. You can create a thing and can give a, or you can, so that is the thing with outflow obstruction. If uterus is present and it is normal anatomy, there is no obstruction, then most commonly we think it is constitutional delay. That is, the mother also would have had a thing, or anybody in the family member, and usually we can wait for, if you do a hormone study and it's normal FSH and LH, we know that it is not, so you can wait for 1 or 2 years before she attains her. She could be like a late bloomer. Also in mind, you have to keep PCOS. Sometimes PCOS very rarely can present in as primary amenorrhea, and prolactinoma can present as primary amenorrhea. So in this juncture, I would also like to tell that sometimes this late onset congenital adrenal hyperplasia can also, but it will usually present as heterosexual. Okay, there is more of hirsutism. So I'm not bringing that here, but mostly we'll think of constitutional delay. So then we come to the next one. So I've integrated this thing as compartment 1. Okay, when we have this normal secondary sexual characteristics, because ovary is functioning there. We come to the next, this thing as absent secondary sexual. So whenever the absent secondary sexual characteristics, then you think there is a problem with it. It could be a problem at the level of ovary or bowel. So when it comes problem with the ovary or the gonad, then the FSH and LH is going to be high. So your next you do is FSH and LH. FSH more than 40 international units. So and it's the compartment 2 problem, also known as hypergonadotrophic hypogonadism. So when the FSH is high, you have, I'm not able to see here. Okay, so if she has a, then you look at the height. If it's a child is short, okay, then you think of, will be a Turner syndrome, 45X. So you can do a karyotyping. Okay, so when a classic Turner, has all the things of Turner. Okay, like Madam was thinking about Turner mosaic. Usually Turner mosaic depends on how much of 45XO is there and how much of 46XX is there. So there can be a border line, like sometimes if it is 46XX is slightly on the more side, they can have a little bit of brief reproductive carrier can be there, some amount of estrogen can be there. So that is also possible, and they can, the Turner mosaic, it depends on how much of this thing is there between 45XO and 46XX. So otherwise it's a short, and with a Turner, what are you going to do? She is a pure Turner, she's a short, and she has gonadotrophins are high. You have to see whether they have other associated things like heart, coarctation of aorta, thyroid is okay, or she's the more chance of developing diabetes. And can you increase her optimal height? Like Sir was telling, we can think of giving growth hormones also. So as far as maturation is concerned, we'll tell in the treatment, how are you going to plan treatment for this pure Turner? If it is a normal height, then it could be a Turner mosaic. Turner mosaic, only thing is, if there is an XY in a Turner mosaic, then the gonad has to come out. But if it is otherwise, we are not removing the gonads in a Turner mosaic. What other thing can be there? Like other than Turner, it could be a 46. Now you're doing a karyotyping and comes as 46XX or 46. That gonad is a dysgenetic gonad. It is not working. Okay, so 46XX it's not working, and so she has uterus, she has all the complements, but FSH and LH is going to be high because it's not working. In 46XY, okay, this is also known as some Swire syndrome. So here the gonad very early, or depends on when it goes out of, it's almost something like a Turner. It has some components of Sertoli, Leydig cells and all, and then they all degenerate. So 46XY, the testis does not work. So there's no AMH, so she has a uterus. So that we know that. So what is our aim in these? It's a very complex thing. You have to see whether how best we can help these gonadal dysgenesis kids. So 46XY, and if it is a gonad which contains 46XY and it is not working, you have to do a gonadectomy. And sometimes in this ovary itself, there can be single gene mutation. So what till now we've been talking about chromosomes. So single gene mutations will be like pre-mutation in FMRI gene, and you can do a mental retardation, pre-mutation, or you can see whether you've got gap. All these are very rare. That does you have 17 alpha hydroxylase deficiency and things like that. Okay. Acquired will be like sometimes the kids are born with cornea, okay, and they have removed the gonad. The gonad was there in the sac and they have removed it. Or it's a childhood cancer and they have given radiation or chemotherapy. So all this can also cause. So we are thinking when the FSH LH is high, the gonad is not functional. And if there is a XY component and it's intra-abdominal, high chances of developing malignancy. So we advocate gonadectomy. Then we go to a situation, this is compartment 2. So when we go to a situation when FSH is low or normal, sometimes FSH will not be absolutely low. It can be even 4 or 5, which is the normal range. Okay, or it will be. But here again, you should remember estrogen is absent. So the absent secondary sexual characteristics. So again, these can be a short height or a normal. So if it's a short height, it could be a congenital pituitary deficiency or a chronic illness, like it could be renal problems or liver disorders. So, okay, they have been living their life with it. So those kids can also go short. Or it could be pituitary adenomas, usually present as secondary amenorrhea, it can present as primary amenorrhea. These pituitary adenomas can produce prolactin, or it could be can produce anything else. Okay? So, or it could be not producing any hormone at all. So null this thing, but it can create a pressure effect. Okay, so that can cause a short height, and or they can be associated with some central facial defects. Those also will present as compartment 3 problem. In this note, to find out this compartment 3 problem and the pituitary, that is FSH is low or normal, their imaging helps you a lot. Okay. So also you have to find out if there are any tumors, any tuberculosis, metastatic carcinomas, things like that. So imaging helps a lot. And if it is of normal height, so FSH, LH is no secondary sexual characteristics. FSH is low or normal, and the kid is of normal height, then you think there is a GnRH deficiency. Okay, so GnRH deficiency is idiopathic, you do not know, but there is a special group of thing which is known as Kallmann syndrome, which is inheritance. It could be autosomal dominant, recessive, or it could be a X-linked also. And here the CAL1 gene is missing. So when the CAL1 gene is missing, there is a protein which is called anosmin that is also not produced. So what happens? These people have GnRH deficiency, and also have loss of smell, like coffee, you cannot smell coffee, things like that. So the thing is, it could be either a idiopathic GnRH deficiency or a Kallmann syndrome, which is just you know what it is. That's it. That it has not moved. The GnRH neurons have not moved at the correct place. That's why it is not. They are not able to. They stop at the level of olfactory bulb. They're not gone beyond. Or it could be some growth there in the hypothalamus where the imaging will help you. Which is the most common one is the craniopharyngeal. So functional also is very important. Actually, I would say that function is also quite common. That is, if a kid has some anorexia nervosa, has bulimia, or if has marathon runner or strenuous exercise, or stress. Nowadays, stress is also very, very important. I have a slide which is showing how does stress help causing anovulation. Okay. So this comes to compartment 3 and 4. So I have, I hope this is usually not given this way, but I thought this will be a better way because I use the compartmental classification, and this I've just integrated it with the absent and presence of secondary sexual characteristics. So management of this, basically once you have diagnosed and you have put them into these compartments, you will have an idea of it. So what is our aim as far as management goes? One is that whether the kid has got a proper sex of rearing, whether she's got how best we can make her functional, like her reproductive function, her height, give her the self-confidence, and also whether if there's any history of missing chances of more malignancy, we should be able to see that we are doing a gonadectomy, see that she does not develop any gonadoblastomas. So, and also make her sexually active. Okay, try to live a full life. And earlier it was very simple. If the external genitalia was female, then they were saying, okay, you have to get it. Even if later on there's a clitoromegaly or a phallus or something, they just remove it. It's easier. But of late, they say that a lot of developments in that particular field, and you have to give the choice to the kid itself. Certain amount, they should also have a say. So compartment 1, I just go at a glance. I'm not going into details. I don't know how much time I have. But so if there's an imperforate hymen, we generally do a hymenectomy, it's a simple procedure. Transverse vaginal, I already told, subcutaneous section. And if this is Mullerian agenesis, we will, I try to get any reports of uterine transplantation and all, but all of you can enlighten me on that. I didn't get anything. But if it is, you create a neovagina. Right? And dilators, they say it works well. I think most of my patients also. Because we try to use, we don't use glass, but we try to use this dental dilator. It works quite well. And generally, these people can be ovum donors. They can go for IVF. They can come to Jairani for IVF. Okay, they can be donors. They have ovary sites. Or in complete androgen insensitivity, we usually do a gonadectomy after attainment of puberty. So, and there is you also create a new vagina. And constitutional delay observation is the Turner syndrome. Yeah, Turner syndrome is the one wherein say growth hormone plays a role, and also there is estrogen we can give, or you can start with estradiol. So what we can do is here the dictum is you have to start low and go slow. I thought that worked very well. So it's not that you have to quickly give them and let them have the period. So you have to see that they are, it is a period of 6 months, 1 year, okay, 1.5 years. Because if you ask them, you see that they attain menarche, then what happens is the height is, you're not helping them. So along with the endocrinologist also, so you have to start low and you have to keep it slow. Slowly you have to increase. Let's say after a year or 1.5 years, you can give the cyclical progesterone. And also as far as they can get pregnant, but you have to go slow on that. You have to see that they are capable of carrying the pregnancy. And they should not be coarctation of iota and things like that, which makes them more problems for the child. Then if it is a gonadal dysgenesis, that's what we are thinking, 46XX, we just give them hormone therapy, but if it's 46XY, then we do a gonadectomy. And in the single gene mutations also, you're just going to give them hormone therapy. So you don't have to remove the gonad. And if it's an acquired thing, again, I've written as cortisol and hormone therapy, because if it is that particular gene, CYP17, because that causes a lot of increase in aldosterone. So they can present with hypertension. So otherwise, these are all very rare ones. We really don't have to. But find out that that is a compartment, ovary is at fault. Then the compartment 3 is that imaging is important. Okay, and to rule out any adenomas. Hormone therapy will be, and if you can give them gonadotrophins when they want to conceive, if they don't have any tumor or and if they have a prolactinoma, then of course you need to give them cabergoline. Otherwise, you can see that you can just put them on hormone therapy and see that they have periods. Compartment 4 is again, because GnRH deficiency is same, either you give OCPs or you give them estradiol followed by progesterone. And you remember these people are estrogen deficient. Okay, bone also should be taken care of. And gonadotrophins can be used only for pregnancy purpose. The functional ones, craniopharyngioma, of course, neurosurgery, and functional ones is they also need a lot of counseling, and you can put them on OCPs or birth control pills. I go to the last thing of just the compartment 4 continue, just to give a glimpse of how complex it is. Hypothalamus, anorexia, how it is related to leptin, and how leptin and our reproductive system is related, catecholamines, glucagon, everything. It alters the pulsatility of the GnRH, and that's how they completely become amenorrhea. Stress also increases cortisol, and this we are seeing quite a lot. And moving into a new place or exams, some people now, all these IT people are also having a lot of stress, and then they have this amenorrhea. Exercise also increases, especially the severe, not the mild ones. I mean, listening to this, some people will think that we shouldn't exercise at all. It's not that. This is a strenuous exercise ones, which increases opioids and increases again alters the pulsatility of GnRH and causes amenorrhea. The last, I didn't make a slide because I really didn't want to discuss about it, but this partial androgen insensitivity syndrome and the congenital adrenal hyperplasia. Mala, do I have some time or?
I think time is up, ma'am.
Okay.
Yeah,
I think I'll just stop this. I have just to summarize. If we put it into a compartment classification and try to integrate for all, of course, we'll take help of endocrinologists, but for us to have a move forward and come to a basic, these two integration of secondary sexual characteristics as well as compartment classification seems a very practical method to me. And any gonad which is carrying an XY, so better to, and it's a position intra-abdominal, better to do a gonadectomy. So thank you for this opportunity.
Yeah, thank you so much, madam. That was really very, very clear, crystal clear, and in fact, very, very up to the point. In fact, we need so much of time to clearly understand this compartmental classification, which you have very beautifully put forward, the various defect in different compartments and its management. Only thing is, I was also thinking, ma'am, so many times you have young girls losing their ovary, and because of that, they are having a primary amenorrhea. wherein because of the torsion, they remove one ovary and then the other ovary doesn't seem to be functioning at all. And because of that, the primary amenorrhea
Very true. Very
happens.
true. Yeah, even I've seen some.
So that is really sad, ma'am. And that I think
Though we tried laparoscopically to fix it.
exactly. Yeah, that is the point where I think we have to really highlight, because that is not mentioned anywhere in our books also. We, out of our own experience, we are seeing patients coming like that with primary amenorrhea and they lose ovary. I have, in fact, 2 patients for whom I had to do a donor egg and IVF and then make a conceive. The second child hasn't got a periods at all. So it's really
with
sad.
adolescent endometriosis. If you're going to see more of those cases, adolescent endometriosis, you're doing an ovarian cystectomy. What happens is that the remaining part of the ovary, whether it's functional or not, and then after 1 or 2 years, again they come with a big cyst. Really don't know.
So we have to be very careful on that, madam. So, madam, thank you so much, madam. That was very, very interesting and enlightening, ma'am. So we'll move on to the next topic now. So for which I would like to welcome our next chairperson, Dr. Sai Lata, madam. So madam is a professor in obstetric and gynec department in the Chettinad Hospital, and she has almost 15 years of teaching experience, and she's been working in the Indian Navy as well, and currently she's also the president in of IMA Kelambakam. So over to madam for to introduce the next speaker and to proceed with the session. Sailata ma'am.
Yes, ma'am. Thank you for the warm introduction and kind words. A very good evening to all the senior logicians, dear friends and colleagues. So now we move on to PCOS, which is not any less important than the 2 other topics we just discussed about. And I'm taking the privilege to introduce Usha Rani madam, who's going to walk us through the various aspects of PCOD, the various diagnostic criteria, the various ways in which they present, the management modalities, etc. So as we all know, PCOS is a very common condition nowadays, and it is a worldwide women's health issue. What with this changing lifestyle, isn't it? Young kids exposed to so much of stress and sedentary lifestyle and very poor, unhealthy eating habits. So many of them are, prone for developing PCOS. And I think all of us need to update about the current criteria, diagnostic criteria and the various diagnosis. Now I want to introduce Usha Rani madam. She is professor and HOD of Obs Gynae in Sri Ramchandra University, Chennai. She has won the best going student award of the batch 1987 from Andhra Medical College and has won many gold medals.
Yeah, Dr.
Madam
Salita, thank you for the
shot. Okay.
Yeah.
It's a lengthy, all good words and nice work by madam. Okay, madam, I request you to take on the talk. Thank you, madam.
Thank you so much. And, polycystic ovary as such, I hope will share my screen. PowerPoint.
Can you share, madam?
Yes, ma'am. Yeah. So PCO, all of us do have the concept, and the problem is mainly when to call an adolescent PCOS as a PCO. And next slide, please. So we have a lot of confusions, and all of us know polycystic ovaries are ovaries with a large number of immature follicles sitting there. So since adolescents already have enough and more of immature oocytes there, so how do we go about in trying to always we try to avoid labeling any person, either a child, an adolescent with any problem. So here we have an adolescent between 10 to 19 years. Next slide, please. So the common issues that we always see in any adolescent is a missed period, irregular period, sometimes light periods. And somebody does a scan outside for some other reason, and they come to us with an ultrasound report saying ovaries are large, there were too many cysts sitting there. Sometimes children are brought with excess body hair or sudden weight gain, oily skin, acne, hair fall, black patches. These are ones which are there even in a normal adolescent. Next slide, please. Next slide. So there is a great deal of overlap between the symptoms of PCOS and normal puberty. And that's exactly what makes a labeling of a polycystic ovarian syndrome in a young lady not too good. Next slide. So now, if you look into the literature or Hedwig's world, there are so many things being said so many times and in so many places. So if you can just, I'm not going to talk about the slide at all. I just marked one in red and one in blue. So the red one says, look at menstrual irregularity, ovarian dysfunction. The one blue always talks about hyperandrogenism. Next slide, please. So now this is an extremely simplified version of how to diagnose or how to think at least of PCOS in an adolescent. People have always tried to split it up between 1 year post-menarche, 1 year to the second year of post-menarche, and 3 years later on post-menarche. Next slide, please. Yeah. So now a young girl attains menarche, and within 1 year, there's no question of talking about polycystic ovary at all. And we never ever use a pelvic ultrasound for diagnosis of a PCOS in adolescent. Next slide. So 1 year is over. So the next year, next 12 months is on. Do we even think of a PCO at this particular point? There are two things should be present. Once again, one in the pink and one in the blue. One says there should be irregular menstrual cycles in such a young child. What is irregularity? More than 90 days of a cycle, or a very frequent cycle, less than 21 or more than 45. Just like how Pushpa ma'am said, a primary amenorrhea. PCOS extremely severe can present as primary amenorrhea, is what most of the endocrine reviews are talking about. But there should be a post-philarchy. So breast development has come, but still for 3 years there is no menstrual cycle. But this should be associated. It's an and there. It's not an or. And hyperandrogenism, which can be either clinical or it can be biochemical hyperandrogenism. We'll try to look into that a little later. So the 12 months to 24 months, you can think of PCO. Once again, we never use an ultrasound to diagnose PCOS in adolescents. Next slide, please. So now what happens? 3 years have gone through. The child who's attained menarche maybe 16 or 17 right now. Do you think of PCOS if the irregular menstrual cycles are more than 90 days, any cycle, or the cycles are now less than 21 or even beyond 35 days itself? The previous one said 45 days. Now it says more than 35 days, provided there is an associated clinical or biochemical hyperandrogenism. Only when there is a combination of these two, you would think in terms of PCO, no ultrasound again. Next slide, please. So now everybody keeps saying clinical, biochemical hyperandrogenism. As clinicians, and especially in a busy OPD, with a variety of cases right from postmenopause to antenatal, we need to have at least 2-3 concepts clear so that we don't miss out anything. Next slide. All of us have gone through this enough and many times. So there are totally about 9 sites to look for. 1 is the lowest and 4 is the maximum amount of hair. So upper lip, chin, breast, abdomen, pubis, arms, thighs, back, and upper back and lower back. So the scoring and all, you can have a maximum of 9 into 4 or minimum of 9. So modified scores also of the Ferriman-Galway, and all of us know enough to say when it is clinically significant. Next slide, please. So when we talk of biochemical hyperandrogenism, this is when sometimes we really are at a loss. So when the patient has got any kind of androgen excess, what are the other things that we as a primary contact person should not miss? We need to differentiate between the physiological hyperandrogenism of puberty, idiopathic hyperandrogenism, the polycystic ovary. We have this non-classical congenital adrenal hyperplasia, androgen secreting tumors, and Cushing's disease. Next slide, please. So, though guidelines differ or recommended laboratory studies, most include measurement of. So, what do we actually do when you find a child with obvious hyperandrogenic features? What investigation should we do? Total testosterone, free testosterone, or both? We've had some endocrine people saying total should not be done, some would vouch for free, and the literature says either this or that or both. And we have the responsibility as a primary contact person for a young girl to do at least a screening for a non-classic CAH or congenital adrenal hyperplasia. Very simple test. We need to just order a 17-hydroxy progesterone level. So elevation of the free or the total testosterone level higher than an adult female normal value is a key diagnostic feature of biochemical hyperandrogenism. Next slide. This is once again one of those very long ones which I'm not going to go through. But to give it in a nutshell, what does it talk about? So you have a hirsute child with irregular cycles. If you can see here, LH, FSH, prolactin, TSH could be ordered. The last three free bar total testosterone or both, DHEAS as a source of adrenal androgen, and 17-OHP. These are the three things which are being added on. Even if you look at the child with irregular menses and hirsutism, you got free and total testosterone, DHEAS, and 17-OHP. We'll go to the next slide. So hyperandrogenism biochemical, when you have a total testosterone of more than 200 nanograms per deciliter, 17-OHP more than 200 nanograms, sorry, I forgot to type it, per deciliter, dehydroepiandrosterone sulfate more than 700 micrograms per deciliter, these things warrant evaluation. We need to have a further evaluation to be done. Next, please. So, why is it that we don't do ultrasounds in adolescent polycystic ovary? Even though pelvic ultrasound and PCO are part of the Rotterdam diagnostic criteria for PCOS in adult women, it is not recommended for the diagnosis of PCOS during adolescence because it can cause overdiagnosis. Second, the international evidence-based guidelines recommended not to use it before 18 or 19. The main two reasons to avoid are, the first is that the majority of the ultrasounds are transabdominal and not transvaginal. Accuracy is poor. The ovarian stroma to the total ratio was significantly higher in adolescents with PCOS when you compare them with even any healthy adult, either with or without PCO. So the ovarian stroma to total area ratio is most significantly correlated with the androgen levels in adolescents with PCOS. So next, please. So can you kindly go back to that long? Go back by 2 slides. One more slide. Go back. One more. Go back. Yep. So a little detail over here. So when the important aspects that we need to keep in our mind when you are talking about hyperandrogenism and ruling out the other problems, if you have any kind of a 17-OHP, which is more than 200, definitely you'll be asking for an endocrine opinion, no doubt. But the adrenal hyperplasia, non-classic, that is when you have a deficit of, where it is a blockage of 21-hydroxylase conversion of the androgen precursors into the further down, the pregnenolone and the rest of the steroid. In the late onset ones, you can have partial expression of these enzymes. So hence, they will not have a major problem, but they will be showing it as a hyperandrogenism. So this one thing is what I wanted to stress before we diagnose a case of PCOS in a young adult, adolescent. Next, please. Next. Yep. So we go to the management goals. Once you have diagnosed or you think that there is a polycystic ovary syndrome in a young adolescent, so what do? Regularize the cycles of the child, regularize the BMI. So the high weight of this child has to be regularized. All of you know enough. Prevent endometrial hyperplasia. So you see many an adolescent having endometrial hyperplasia and using large amounts of norethistron, heavy doses in order to control the abnormal uterine bleedings. Heavy menstrual bleed is another important part of this polycystic ovarian adolescence, wherein large periods of amenorrhea are followed by bleeds which cannot be controlled unless you start them on some amount of estrogen-based treatment, because the shed endometrium will not regenerate well. And we have seen adolescents, 18, 19, young adults, 20, 21, the combination of severe anemia, heavy doses of tranexamic acid, and 19-not-testosterone derivatives like Primalet or Regestrone or whichever, leading to cerebral accidents. They have had venous thrombosis. We've had children, late adults, 18, 19, 20s, with even hemiparesis, hemiplegias. So we have a great responsibility in emphasizing that regularizing the cycles is extremely important, and that little bit of progesterone that we add on to give them a regular withdrawal will prevent a large amount of morbidity. Next slide, please. So BMI reduction, we know, more easily told than done, but with the present day and all the problems of the way the children are always either with the books or the television or the net. Metformin, the role of it is advised only when there is an abnormal OGTT and which is not responding to lifestyle changes. Then you can add metformin, 6 months or a year. Oral contraceptive pills can be given, but all of us know we can't give it forever. I personally feel that intermittent progestins would be the best in this adolescent polycystic ovary group, wherein it is very important to educate the patient, her parent, that 45 days or 50 days of amenorrhea should be broken down with addition of a simple methoxyprogesterone acetate for a 5-day or a 7-day pill. In fact, we need to put in this concept, saying it is something like a hormone replacement, rather than saying we are giving you hormones or something, just like how you have a thyroid deficiency, you're taking it. You've got a total anovulation over here. So take just 1 week of progesterone as a replacement, and that will go a long way in preventing a lot of problems for the PCO adolescent. Next, please. Thank you.
Yeah, Sailata, madam.
Yes, madam. That was a rather crisp and very clear and to the point presentation on PCOS, madam. And it has conveyed a lot of message to the listeners, especially regarding the diagnosis, wherein we are not supposed to use ultrasound in the diagnosis, though Rotterdam criteria, includes it as one of the criteria. And also in the diagnostic tools, since PCOS is a condition of exclusion, so it's rather, more than directing towards the diagnosis of PCOS, we need to exclude all other conditions. And you went through it very well. It was very enlightening. The management goals also, you very clearly said that intermittent progesterone is the best way to go. And we have to break the cycle every once in 45 days. And also we would like to add to counsel the parents as well as the girl, the necessity of, the awareness regarding the long-term risks in this girl and how to avoid it can very well be avoided with lifestyle modification. Thank you so much, madam, for the wonderful session. And I had the privilege to chair the session.
Thank you. Thank you so much.
Thank you so much, Sailata Madam and Usha Rani Madam. That was really excellent. So we have very clearly highlighted and very aptly said, once a PCOS, always a PCOS. So you should be very careful before we diagnose a young girl with PCOS, because she'll go with that report all over, and all through her life, everyone who sees her will brand her PCOS. So I think that you very beautifully you have highlighted and how wonderfully we have to manage all of that. So we are running short of time, ma'am. So we move on to the next topic. So for which I would like to invite our next speaker, Chairperson, Dr. Dhanlakshmi Madam. So Madam, as everyone knows, we know the phenomenal work Madam did last year as an honorary secretary of Oxy. She is currently the professor in OBG in Sri Ramchandra Medical College and is an excellent teacher. She is also she has also been awarded the AL Mudaliar for Travel Fellowship. And over to Madam to introduce the next speaker and to carry on. Thank you so much.
Thank you, Mala. I'm just waiting for the CV of Dr.
Chitrakala? Yeah.
Deepa Tyagaraja-Murthy. She's well known among the RCOG circles, and she has been an excellent speaker. She's a consultant OB/GYN with specialization in infertility. She's a visiting consultant in Motherhood Cloud9, Covering Hospital and Apollo Spectra. She had worked in UK before coming to India. She teaches the DNB students of Visibles, and she's a fellow representative of IRC RCOG India South, and she's an executive committee member of ATN RCOG MRCOG Part 3 examiner. We are eagerly waiting for your talk, Dr. Deepa.
Thank you, ma'am. Thank you for the kind introduction, and thank you very much to Dr. Malaraj and Dr. Jairani Kamraj to give me this opportunity. It's a very interesting topic they've given me. Can you see that, ma'am?
Yes, ma'am.
Yeah. The topic is adolescent endometriosis. I'm not going to go into the details of endometriosis. You all know what it is. Cells similar to those in the endometrium grows outside the uterus. So what is adolescent age? All the papers which I went through says between 13 to 21 is considered as adolescent age. And can endometriosis occur at such a small age, 13 or from menarche? Yes, it can. The problem is we do not think about this diagnosis. Whenever a mother brings a small child, 14, 15-year-old with abdominal pain, the common thing which goes through our mind is, oh, could it be worms? Could it be stress eating? Could it be, junk food? And somewhere in the corner of our mind, we never think about this endometriosis. So at the end of this talk, if you can remember to think about endometriosis as one of your differential diagnoses, I would have achieved the purpose. So endometriosis in the adolescent age is an enigma, and the main problem is a delayed diagnosis. Templeman says if women and doctors become more aware of the problem, early diagnosis can be made, which is very true. Why is there a delay in diagnosis? We never talk about menstruation. There's such a taboo in this country to talk about menstruation, and not even the mother and daughter talk about, the menstruation. Leave alone that. Even children in the school circles don't talk about their menstruation experiences. If only they spoke to each other, they would understand that what they are going through if they have endometriosis is something very different to compare to other kids who are having menstruation. So mainly it's the lack of knowledge about the symptoms suggestive of endometriosis. Not only that, all these school personnel who look after these children, they don't know anything about identifying symptoms suggestive of endometriosis. Not only that, we do not have proper non-invasive tools to diagnose this problem. So adolescents are mainly overlooked. They present with very vague abdominal symptoms, sometimes gastrointestinal distress, sometimes genitourinary symptoms. Initially, they will see their family physician, and they get misdiagnosed most of the time as PID, which can be, can produce huge psychological impact. They can also be misdiagnosed as irritable bowel syndrome. They're evaluated by various physicians, sometimes orthopedic, sometimes gastrointestinal, by the time they land up with a gynecologist. So the diagnosis increase. Somebody thought, okay, fine, this adolescents are presenting with abdominal pain, and this is not responding to any of the normal medication. Why not we do a laparoscopy? So the diagnosis increased after the use of laparoscopy, and they saw that the prevalence was anywhere between 19 to 73%. And the laparoscopy for this kind of investigation for adolescents started as early as 1980, and they found that the prevalence of endometriosis in adolescents was as high as 50% in girls with pelvic pain. And they also saw that 65% prevalence in adolescents and symptomatic teenagers with continued pelvic pain, which continued in spite of treatment with NSAID and cyclical oral contraceptive pills. So there's a study which looked at 880 adolescents, 10 to 21 years with dysmenorrhea or pelvic pain, and they showed that endometriosis was seen in 62% of the adolescent women, 49% in women with chronic pelvic pain, 70% in those with dysmenorrhea, and 75% in women with chronic pelvic pain resistant to medical therapy. So when they did a laparoscopy, they also found that the lesions were not very typical powder burn lesions. They saw a lot of red or clear vesicles, and the prevalence was as high as 52%. Then came the idea of using ultrasound scan. In India, we don't have that many kids who are sexually active very early in life. But when you go abroad, kids are sexually active right from 14, 15 years of age. And then they thought of why not use transvaginal ultrasound scan in these sexually active kids. So with the introduction of transvaginal ultrasound scan, the increase in diagnosis of ovarian endometriomas happened. And again, when you see adolescents, they don't have the typical signs which you see in adults. The endometriomas are much smaller. They have site-specific tenderness. There may be reduced ovarian mobility. And if you do a transvaginal ultrasound scan, you could see a absence of the sliding sign where the organs slide over the bowel. Now, once they started diagnosing this with laparoscopy and transvaginal scan, they thought of gathering more information. When they did more of information gathering, they saw that 60% of adult patients with endometriosis, their symptom had started way before they reached 20 years of age. And they also saw that there were certain markers of deeply infiltrating endometriosis, which were seen during adolescence. That is, these kids missed more school during their menstruation. They had long periods of use of Oxy pill to treat their dysmenorrhea. They had serious GI symptoms like constipation, diarrhea, nausea, and vomiting. Then they also saw that Bat and Mitwally said, don't use Menarche. Let us use Thelarche as a marker to include endometriosis in the diagnosis for girls complaining of chronic pelvic pain. And how long does it take after Menarche for them to develop this endometriosis? The shortest interval they've seen is 3.5 months in developing endometriosis after menstruation. And in the youngest girl with endometriosis, who was 10.5 years old, the onset of symptoms took about 5 months. But on an average, it takes about less than 1 year to 5.5 years after Menarche to develop endometriosis. Now, unfortunately, this is a progressive disease. How are we going to see in this adolescent whether this disease is progressing or not? So the assessment of progression is very, very difficult. You need to do a second look laparoscopy, but how many of you would be given permission to do this? It's an invasive test and it's not indicated. And also, if you do a second look laparoscopy, it is difficult to differentiate the adhesions from endometriotic lesions because most of them are atypical and subtle lesions. And normal looking peritoneum may also show endometriosis on scanning electron microscopy. And also, this is a severe disease. Now, severe disease was seen more so in girls who had an obstructive Mullerian tract anomaly. Now, the incidence in adolescents with genital tract anomalies was 6.5 to 40%, and non-obstructive anomalies is not a risk factor. And the commonest sites in these obstructive Mullerian duct anomalies is ovaries, rectovaginal pouch endometriosis, and on the uterosacral ligaments. Now, the recent studies have shown that adolescent endometriosis is no longer just subtle lesions. It's no longer just stage 1 and stage 2. Better diagnostic tools are showing the progression through stage 3 and 4, and you're seeing more severe cases with extensive adhesions and endometriomas. Does this adolescent endometriosis affect your chance of bearing a child? They did an 8.5-year follow-up of 28 adolescents from stage 1 to stage 4, and all had had surgery followed by 6 months of combined oral contraceptive pill. And they showed that there's a linear decrease in fecundability with each revised American Fertility Society stage. With stage 1, the chance of becoming pregnant was 75%. With stage 2, it's 55. Stage 3, it's 25. And stage 4, it's almost 0%. How is this adolescent endometriosis morphologically different from adult lesions? Now, we already saw that you see a high percentage of subtle, clear red or vesicular implants on laparoscopy. And also when you have the deep endometriosis, the lesions are between 3 to 5 mm, whereas in adults, you see a more than 5 millimeter thickness or adenomyotic type of endometriosis. You also see in adolescents peritoneal pockets with endometriosis in up to 17% of the cases. What is the pathogenesis? More research is needed. It's a complex pathogenesis. The one factor which causes endometriosis is menstruation. Now, the disease is more severe in genital tract outflow obstruction. They've also seen premenarchal and adolescent endometriosis. What they say is there is endometrial shedding which happens from neonates in 5% of the neonates. So this endometrium shedding leaves endometrial stem cells in the peritoneal cavity. Once the ovarian activity happens, once they just before menarche, this causes VEGF stimulation of the angiogenesis, and this causes the petechial lesions and the adhesions. And the pathophysiology in the adolescent is a mystery once again. There's a series of predictors of endometriosis. Adolescents can be at more risk factors. What are these risk factors which could indicate endometriosis? Early menarche, duration of the menstrual cycle and bleeding, a family history of a first-degree relative with endometriosis, smoking, asthma, and congenital anomalies. This is a hidden disease, and the symptoms could be very varied. They could present with dysmenorrhea or a very acyclic chronic pain, which is resistant to combined oral contraceptive and NSAID. They could have acute pain, heavy menstrual bleeding, irregular uterine bleeding, gastrointestinal symptoms, or genitourinary symptoms. And we use the revised American Fertility Society staging classification. How do we treat them? The first line of treatment is combined oral contraceptives. Either you give it cyclically or continuous or extended cycle, and the NSAID. GnRH agonists or antagonists should be postponed until 17 years of age because of ongoing bone development. And it should be used only in patients who have been definitely diagnosed using laparoscopy. We can also use long-term progestins like a levonorgestrel IUS. 86% showed a good continuation rate 1 year later. 51% achieved amenorrhea. It is well tolerated. It is very safe. I personally have used it in UK. I've inserted for 2 women. But what is the long-term effect on bone density needs to be seen. Cochrane review also says you can use mifepristone, which is a selective progesterone receptor modulator. This reduces the dysmenorrhea and it improves the surgery outcome. But what is the safety in long-term use? We do not have sufficient evidence. Conservative treatment using surgery. We either ablate the endometriotic lesions, or if there is an endometriotic cyst, we remove the endometriotic cyst. Post-operatively, definitely these women will need combined oral contraceptive and or LNG IUS. 1 year post-surgery, what they saw was 64% had a complete resolution of their pain, 16% had improved pain, 12% continued to have pain, 8% the pain initially improved but it returned, and recurrence rates were also high if you do not continue the medication. So post-operatively, hormone medication will prevent your recurrence, but only long-term medication will prevent recurrence on the long run. And importantly, repeated surgeries should not be done. This will lead to decrease in your AMH levels and decrease in your ovarian reserve. What else can they do to relieve pain? which we all know: heat, exercise, massage, more sleep, a balanced diet, drinking more water, meditation, and mindful movement like yoga or Tai Chi. So to conclude, endometriosis is difficult to diagnose in adolescents. They are less aware of their condition, and so are we. Characteristics of adolescent endometriosis is very different from the adults. Atypical symptoms and subtle early stage lesions, which are less evident on imaging, makes the diagnosis very difficult. Symptoms are usually resistant to combined oral contraceptive and the NSAID. GnRH agonist use is postponed until completion of osteogenesis. LNG-IUS is safe and effective, but the long-term effects on future fertility and bone density need to be seen. New medications are being studied. The precise timing of surgery is very, very important, and recurrent surgery should definitely be avoided. Very important to educate the women, the parents, the high school personnel, and the general physicians regarding the symptoms suggestive of endometriosis and adolescent endometriosis. Everybody should have access to information, and most important, we should have destigmatization campaigns telling them not to stigmatize menstruation and talk more about menstruation. Early diagnosis and treatment of endometriosis is very, very important. The important message is see and treat, as the prevalence of adolescent endometriosis is quite high. This will resolve their pain, may resolve their pain. It will prevent disease progression. It will prevent organ damage, and it will preserve the fertility for the young adolescent women. Thank you very much. Hope all of us will think about adolescent endometriosis whenever a young girl walks into our clinic with a vague abdominal pain.
Thank you, Deepa. That was a wonderful talk. I know we are becoming more and more aware about this endometriosis. So unless otherwise proved, we always think of pain in an adolescent girl, even though related to menstruation, is endometriosis with the availability of high-end ultrasound machines. Okay, even a transabdominal ultrasound does pick up. And there's a dilemma when the endometrioma is between 3 and 5 centimeters. Yes. So 3, you can give medical treatment. More than 5, you can offer surgical. Between 3 and 5, we are caught in a dilemma. But of course, as young girls, it's very difficult to pronounce surgery as the first line of management. As you rightly said, let us all be aware about this endometriosis. Let us catch them young. And the best way is to put them on OC pills. Okay, so beyond 17 years, you don't hesitate in putting them on OC pills. And they do very well. And it solves both the Usha's dilemma and your dilemma as well. And thank you, Mala, and thank you, Jairani Madam, for giving me this opportunity to chair this wonderful session. And over to Mala.
Thank you so much, Dana Madam and Deepa, Dr. Deepa, for a wonderful session on endometriosis in adolescent. 2 important points. The most important thing is delay in diagnosis in adolescent endometriosis. And the second thing is early surgical intervention in adolescent endometriosis to be avoided. So these are the two things like generally we kind of think about when it comes to adolescent endometriosis. So we are not taking any questions. We move on to the next most awaited panel for the entire session. That is a panel on hormonal dysfunction in adolescent, for which we have 2 experts on this panel and also a moderator. The 2 experts are Dr. Cynthia Alexander Madam, who is a former director of IOG and superintendent of government hospital of
Mala, we'll skip.
Madam.
I think we are already late.
Yes, madam.
Late.
Okay.
We'll just
Chitrakala, next slide, please. And also another eminent gynecologist, madam, is of course known to everyone, the past president of Oxy and of course the HOD of KMC. And
we are late, Mala.
Yeah, the moderator of our panel is Dr. Vijayalakshmi Sheshandri, madam. Again, was a past president of Oxy and was a senior consultant in SMF and also has held various top positions in various committees. Over to you, madam, to go ahead.
Sure. Am I audible? Yeah. Can I share the screen? I think I will just say a few words when I'm taking the. Hey, give me opportunity for sharing screen, please. Yeah.
Yes, ma'am. You can share, ma'am.
No.
So we have come to the grand finale of today's.
Screen. Give the option. Yeah, please. Thank you. Am I okay?
Yes.
Yes, ma'am,
Yeah,
it's visible, ma'am.
Yeah. I will do.
Yeah.
So I'll have to, where is my hourglass?
Down, madam.
Yeah. Is it
A
okay?
right person for moderation because she's also a law person.
Madam. Thank you, madam. Thanks, India, madam, and Shanti. I'm well aware that you have been here as experts. So obviously, whatever we all talk, still you will have every chance to rectify and add on your comments probably at the end. My job is also made very easy because the time is going close to dinner time. So not too many enthusiastic audience perhaps. And also because of the 4 talks, which really covered a lot of endocrinology in adolescents. And because I saw those topics on endocrinology, I thought I will just take a few topics which may not have so much of overlap with the previous talks. And so I have chosen very, very specific 3 cases where we will try to get on with some opinions. Now, we know adolescence is a period of transition, and it's also a link between the childhood and the adulthood. And therefore, it faces lots of physical, biological, emotional challenges. And also, it has a very landmark situation where there is puberty, which affects the growth, metabolism, and the future fertility potential. So whatever we say, whether we call it as an early 11 to 14 years or middle 15 to 17 years, or even later 18 to 21 years of adolescence, endocrines rule this period. And I'm really happy that I've been given this topic where I had the real opportunity to even grope in further in this, the endocrinology in adolescence. Thank you, Mala. Thank you, Jairani and Kundavi, for this opportunity. Now, when we talk about all these problems, I have a great list of panelists, just the 4, but all of them very heavy, because Dr. Shanta Bhaskaran, I know very, very good with the academics for several years. And she was heading department in railways. And then now after retirement has gone to Apollo. Then, of course, MG Dhanalakshmi, we all know, a very good academician, and of course, in Srihar, and was also very efficient secretary of Oxy earlier. Mohana Pramila has joined as a very young and a new block into the EC committee of Oxy, and we really have lots of hopes from her. And of course, our savior for the day, Anjali Satya, the endocrinologist herself, who will be able to help us out whenever we have some kinds of tumbling situations. So thank you all of you for joining this panel, and we move ahead. Now, I will directly go on to a cases just for the initiation, and probably then we will be able to really discuss what exactly is the scenario where we need to work on these cases. Now, this is a 15-year-old girl with an age of menarche, 12 years, meaning last 3 years she's been on, she has got periods, but they have been irregular, and LMP was 3 weeks back, and the BMI of 25, and 1 year back, she did come for consultation. We know how the mothers are concerned with the irregularity of the periods, but she was advised to be on wait and watch. As we all know, HPO axis immaturity is something which we always know, and we do not hurry to take care of this irregularity. So we advised her, and she went back, but now has come back with a different concern. And the concern is concerns of severe acne or pimples, as we call them, and excessive hair growth on the face, especially on the chin and upper lip. So the psychological effects are unbearable for her, and she's very uncomfortable and has an unfeminine feeling, as she described. And this is where we have to really go into our thoughts. So I would like to know let us start from the youngest. Mohana Pramila, what are your thoughts on this particular case? This is just an initiation of the talk. And of course, we know Dr. Usha has covered a lot on this, but still, let me go ahead and quickly go through the case. Yes, Mohana Pramila, what are your thoughts on this?
This girl attained, this girl has attained menarche at 12 years. Now she is 15 years, 3 years of menarche, but still she is having irregular period. It is an anovulation, and top of that she is having a sign of hyperandrogenism, which is a concern, the acne and excessive hair growth. So we need to evaluate the hyperandrogenism part, whether she is having an ovulatory dysfunction associated with hyperandrogenism. So we need to do some biological, that is laboratory investigations to arrive at the diagnosis.
Good, thank you. And so we call this as hirsutism. So what is hirsutism? Just for the benefit of everyone, just a small differentiation. Yes, Mohana Pramila, complete this.
Yes, it is the male pattern of hair growth, that is vellus hair, to terminal. Terminal hair is a dark, thick and coarse hair in the androgen sensitive areas like chin, chest, breast, abdomen and upper part of the thigh. The hypertrichosis is the excessive hair growth anywhere in the body. According to that, we give a Ferriman-Galway scoring of 9 areas in the...
So Dr. Usha did cover this Ferriman-Galway score, the modified Ferriman-Galway score, where we have excluded the lower leg and the lower thigh, lower arms, the forearms. And therefore, there are 9 points she has already described. So let us not go into the detail of this, just to take care of the time. And so there is a possibility that we may give her a score and then move ahead, thinking that we may be able to have a little bit of discussion on the hirsutism. Now, causes of hirsutism. Can you, Dr. Dhanalakshmi, can you please tell me about the causes of hirsutism?
The main cause would be PCO, ma'am.
Yeah.
Okay, and the other causes we have to rule out as routine. And some of the thyroid disorders can present as with hyperandrogenic features. And for hyperprolactinemia, I would rather blame this some of the tablets which she had been taking, maybe antipsychotics and all that. Okay, and parent syndrome is another manifestation of insulin resistance. Anyway, if Mohana Pramila has already done a lot of investigations, I hope she had included insulin, fasting insulin, and GTT to complete the show. Non-endocrine factors could be this minoxidil. Now, sometimes they go to the dermatologist with the hair loss and all that. Sometimes they are given this, and excess can produce hirsutism in other parts as well. And I don't think we are encountering this methyl-endopard-dinosol, at least in this adolescent age group. They do not use this.
So, yeah. So we do have a list of the causations for hirsutism, and we can think of them. And as Dhanalakshmi correctly pointed out, that in this age, probably we are thinking more on the polycystic ovaries, unless a congenital adrenal hyperplasia, the non-classical type, was not diagnosed earlier. And of course, a little bit of burden goes on the thyroid and the pituitary. So keeping all this in mind, we need to really go ahead with the discussion on the how to proceed overall. So just a small touch upon the androgens. Then we have the androstenedione, which gets converted to testosterone in the adrenal and in ovary, and gets into either a free testosterone or bound to serum binding globulins, which is coming from liver. And of course, DHEAs or dehydroepiandrosterone sulfate has an adrenal source and therefore points out. So I'm not going to go into the real theoretical explanation of all this, but just to keep a nutshell on this so that we know what to do with these hirsute young girls. So, Dr. Shanta, what do we do with the history? Do you need any more this thing, or we grope in more or investigations? What would you advise?
Of course, a detailed drug history, I think Dr. Dhanalakshmi has already mentioned.
Yes.
And what else? I think history has been covered. Examination, I just want to add a few things, like, you have to look for markers of insulin resistance like acanthosis nigricans. And this particular patient that you presented, I was just wondering, even though 3 years has elapsed since, her periods, the periodicity, the regularity has not yet commenced, because you expected HPO axis to mature by the end of 3 years. Sometimes it can take a little longer. And you did mention about a little bit of hair growth if the patient was concerned in the face. And I would like to mention that, sometimes these adolescent girls, they can have, I've also seen a lot of girls who actually haven't been labeled as PCOS, but they are concerned about it. They can have a little bit of hair, a little bit, not too much, on the upper lip and also upper lip especially, and perioral hair. Okay, I was wondering whether this is something like that. And if she does not have any markers of insulin, and
Yeah,
she's
we will.
overweight, I think you
Yeah,
mentioned her
we will.
BMI was 24.
Yeah.
25, 24, 25. So it's slightly on the higher side. So I still do not know whether it's a case of PCOS or whether we're
No,
just
we are not really labeling her right now as PCO.
Yeah, we're not yet
only
labeling,
just having a working diagnosis, and we are just thinking what else could be there in hirsutism, because hirsutism is a large panorama and we need to really look into.
And
So,
ruling out, you've ruled out thyroid, you've ruled out prolactin, you've done it, it's all normal.
Okay. Yeah, all normal. And here, a little bit, we need to really also associate this hirsutism with the pubertal development, and then the way it progresses, and whether generally, whether acne is there, balding is there, hair loss is there, and does it really change the face contour? Nothing was here in this age group. Of course, it's a little probably early, and we have to take a complete detailed history on medications, as we have seen the long list which could cause hirsutism, and of course, the metabolic disorders and family history, because some are just the familiar hirsutism which can sit in.
Family history, and one more thing is, many of these girls actually don't even tell us when we examine them that they've resorted to hair removing methods, or they wear clothes which fully covered, and and when you ask them to take it out, they don't. That is very important. I forgot to tell you.
Yeah, very true. When we are asking, we must say whatever we can see on your face or hands. Is it after shaving or
removing? Hair removing tactics? Yeah.
True. True. And none of them, they may admit, they may not admit, but generally when we ask, they do admit what.
When you ask them a direct question, they do say, but you shouldn't, expect it to come
you
from
cannot
them
presume
on their own.
So the investigations which we would go ahead, Anjali, all hormones, and we come to you. So Anjali, Satya, please join.
I think I'll summarize this case first.
Yeah,
as a physician, how I would look at her would be an overweight young adolescent, 3 years post-menarche, and she has now presented with hyperandrogenism. Now, what we try to see is now 3 years, yes, majority of the HPO axis can take slightly longer, as Madam just mentioned, sometimes even more than 2 years. But when anovulation is coupled with hyperandrogenism, again, what we need to highlight is to see the degree of hyperandrogenism. So what we as a physician look for is, are there any signs of virilization, which may be very soft signs, change in voice, temporal recession of hairline, increase in muscle bulk, clitoromegaly. So a simple clinical examination would make us think of much serious underlying problems. So the degree of hyperandrogenism, if it is very mild, it can still be part of anovulatory cycle. It need not be a clear-cut indicator of PCOS, but moderate to severe hyperandrogenism definitely needs to. So we think of several differentials when we are seeing a person. PCOS is a diagnosis of exclusion, but it's most common. And so after ruling out signs of virilization, if there are even subtle signs of virilization like temporal recession of hairline, then we would think of non-classical CAH. We would look for the what is a pattern of fat distribution. Is there any likelihood of Cushing's? They may present at this age or there could be even if the rapidity of, she said the hyperandrogenism happened later. If it is a recent onset, rapidly progressive hirsutism, we think of even more serious problems, neoplastic lesions, androgen secreting tumors. So how we approach the person would be totally dependent on our physical findings. So here is a young girl, our first differential, we would still consider overweight, young girl, adolescent with anovulation and hyperandrogenism. We'll think of PCOS. So we look at two things. One is biochemical evidence of hyperandrogenism, and second is a metabolic profile. As we know that insulin resistance is the underlying factor. So we would screen her with either a fasting blood sugar or GTT, 75 gram GTT, do a fasting lipid profile, look for markers of hepatic steatosis. So what we see is on inspection, if we find that the child is overweight or obese, and we look at her waist circumference, we don't measure it routinely, but anything above 88 centimeters is considered significant. So we would expect hepatic steatosis, fatty liver, very high prevalence in young girls with, so we do a SGPT, other markers of insulin resistance. Sometimes even they may have hyperuricemia. Now, what are the tests which we would like to confirm biochemical evidence? We would look for total testosterone, because free testosterone assays that is currently available in laboratories is not very standard. So total testosterone, why we check total testosterone? Because if the value is significantly high, normal would be considered less than 55 nanogram per dl, but anything above 1 is considered a higher grade of hyperandrogenism, and any value above 2 is tumoral, unless proven otherwise. So values which are on the higher side, then we would look for where the source of testosterone is. So DHEA sulfate form is specific to adrenals. So if you have a high testosterone with high DHEAs, more than 700 microgram, it could be tumor from an androgen secreting tumor from adrenal. But in general, by and large, what we see in women with PCOS is only a little slightly higher testosterone levels, which may not be very significant. And DHEAs need not be routinely checked in these women unless we are suspecting a tumoral cause from adrenal gland. We also rule out, check prolactin levels in any young girl who has hyperandrogenism and anovulation. And if a clinical diagnosis of PCOS is in question, we would definitely screen the thyroid function in all these young girls. So these are the three basic things. We ask for 17-hydroxyprogesterone in follicular phase only if the degree of hirsutism is very severe, or if you find that the testosterone levels are exceeding 1. Then we would check for a basal 17-hydroxyprogesterone in the early follicular phase at 8 a.m. in the fasting state. Because if you check the levels way down or later in the day, the values may be falsely low. Now in 17-OHP, if the value exceeds 2, then we call them back for what is called as a 250 microgram synactin test, where we give synactin, which is now available as Syntropac, 250 microgram single ampule, which we give IV. This test can be done at any time of the day. And once we give the injection, we check the 17-OHP 1 hour later. Now, what we see is the basal and the stimulated values, and we have a plot, a nomogram, on which we have a plot which plots between basal and that is available on the net. And here we can identify if the values are significantly higher. Say the stimulated value is more than 10, we may be dealing with non-classic CH. Cushing's, if we suspect, when do we suspect Cushing's? Is a young girl who has centripetal obesity, may not have striae, maybe a rapid weight gain. They may actually become amenorrheic because of high cortisol levels. Here we do a simple screening test called as overnight DEXA suppression test, where we give dexamethasone 0.5 milligram, 2 tablets at 11 o'clock in the night for any young girl who is weighing less than 80 kilos. The ones who weigh more than 80, we give 3 tablets, 1.5 mg dexamethasone at 11 p.m. and check the cortisol the next day. Now, normally cortisol should get suppressed in this test, less than 1.5. If it is not suppressed, then we go ahead with further investigations.
Thank you. Thank you. That was the entire endocrinology right there. So, of course, this imaging, as we all know, PCO is not diagnosed. I think even till 8 years from menarche, that's what they say by USG, but we are not just thinking of PCO, but we are really looking into if we can find something more and therefore some radiology. What about the opinion on karyotyping? Not required at this age, or do we do? Shanta?
No, karyotyping is not required because, I mean, what are we going to pick up, isn't it? What are you thinking of? I definitely wouldn't think.
I'm not thinking, that's why I put that question mark, because I think it's not really required, although some advice, but I'm sure this is not required.
As far as I know, there's not.
So, sorry. So now, having done the investigations, and here, of course, all the results were negative, and we just put her under a working diagnosis of mild hirsutism with polycystic ovaries, because though the scan diagnosis is not there, we don't this thing, but just by the history, possible diagnosis, because in fact, all thyroid, prolactin, everything was normal, and these suppression tests which Anjali detailed out were all normal as well. And there was a slight elevation of the testosterone, and that's it. Now, so keeping...
Can I just add one point?
Yeah, please, Shanta.
Now, since we cannot rely on the ultrasound to pick up PCOS picture,
Yeah.
because as Dr. Usha has mentioned, you can't do a transvaginal, and also because of the newer machines that we're using are the better resolution probes and all that. The 10 follicles of the whatever less than 10 millimeter, 2 to 8 millimeter, and all that no longer applies. But we can still take the ovarian volume. But whatever it is, we are not doing transvaginal; we're doing transabdominal.
Although most of the scan reports will read polycystic ovaries,
polycystic. Yeah, exactly. All ultrasoundologists will give a picture. They'll actually state it over there as a polycystic ovarian disease. Whether we can do AMH, in fact, I started resorting
they say AMH is not to be used for the diagnosis of PCO. If I'm right, Anjali?
Yes.
Yeah.
Anything more than 4 or 5 ng.
It can give us a clue. A higher AMH value, say in 4 to 6 or 8. Yes, yes.
I do AMH and I find it.
But it is considered currently. It's not recommended as a.
Currently, yeah. There is no. I did go through that literature, but they said AMH not to be used.
I've read a couple of articles, and they do ask us. They do say, well, you can think of. It's not the evidence based, but you can think of doing it when in doubt, because we cannot resort to ultrasound and any 2 out of the 3 features going by the Rotterdam criteria. AMH can be taken as a marker, surrogate marker.
Okay. So now we go on to the management part. How now this patient has presented to us. What do I tell her? The pharmacological, non-pharmacological for a broad outline. Can we tell about non-pharmacological, Mohana?
Yes, ma'am. She is more than polycystic. Yeah, more than a polycystic ovaries. This girl has got a high risk for the metabolic.
What she's concerned is more
metabolic syndrome. She is a high risk candidate for metabolic syndrome in the future. So I am more concerned about the lifestyle modification at this age itself. So I need to give her a proper diet and exercise. This diet chart we have to incorporate. It should be a practical one to follow. It's not like a fancy diet like keto diet or exclusive intermittent fasting like that. And the girl will follow quite a few days. Then again a rebound increase in the weight will come. So we have to give them a diet which is easily available at home, as well as it will be easy to follow her. So we have to put her in calorie deficit, and also we have to teach entire family how to have that portion control on the diet, and low carb diet, high fiber. And keeping this in the mind, we have to incorporate and give a practical tips to how to have a diet in a routine dietary pattern.
Hi, Dhanalakshmi. Let me bring you in about how you manage this excess hair, the non-pharmacological method. We will go into pharmacological a little later. Dhana?
Non-pharmacological, we can ask her to visit a good dermatologist, okay, for temporary relief. But we should make her aware only the future hair that is going to come is going to be avoided. Okay, the hair which is already formed and become a terminal hair, they can only be, they are allowed to wait for they can go for the complete treatment with the epilation, not the regular kind of shaving or using a hair removal cream that will only remove the superficial ones. But for a complete removal of this terminal hair, she has to go in for a laser treatment, and that give her relief. And of course, as Mona Premila said, we have to teach her about the proper diet. That is going to help her a lot.
So we can advise her on these, what successes she may expect, she may not expect, because that is the main concern that brought her to us. How do I go to the school? How do I go get exposed to the society? I'm having these problems. Of course, now for the last 3 years with the mask on, I think the problems are less cosmetically seen, but definitely the girls do have a problem in this age group when they are really so very worried about their cosmesis. So these things probably can help. Yeah, Shanta. Yeah, Shanta.
Yeah, if non-pharmacological, probably if she's getting at least periods once in 3 months, because you mentioned irregular periods, so we do not know the regularity or the periodicity of how often
she was
has to get at least 4 periods in a year.
Yeah.
If she's not getting 4 periods in a year, no question, you have to add progesterone or something and ask her to take periods. Ask her to ensure that she gets periods at least 3 months. Otherwise, if she's getting it before, well before 3 months, then perhaps you could resort to this non-pharmacological method. And as Dr. Mona said, weight, diet, and exercise and things like that.
Yeah.
Yoga.
So with the lifestyle modification, easier said than done. They hardly do, though we keep stressing. And then weight is a constant issue. And of course, the central obesity as well. So now we move on to the pharmacological management. So I've just listed out all these. I want to ask Anjali, how good are we at using them? And pertaining to the adolescent issue, plus otherwise also, what are the prescriptions that can go on with this group?
So the treatment of hirsutism would largely depend on what is the grade of hirsutism.
Yeah.
And also how irregular or regular the cycles are. Sometimes women only have hirsutism with regular cycles.
Yeah.
So we have different kind of presentation. Now, if there is irregular cycle with moderate, severe hirsutism, I think oral contraceptive pill is the best choice. Now, physical methods should always be offered because that gives a temporary relief. And as we said that even weight loss of 5% can lead to regularization of cycle. So lifestyle modification, though it's an easy advice to give. Just 2 days ago, I had a very bad experience online where a patient just hung up on the phone saying that she was psychologically disturbed because every doctor whom she has seen has been talking on weight loss. And she has been having depression, anxiety. So these individuals have severe body image issues. So we have to be very sensitive when we talk about weight loss, even to a young adolescent. Already they are facing a lot of rebuke and criticism and maybe, body shaming at school and colleges.
I want you to comment on these. Are they useful, not useful?
Yeah. So OC
to be
pills is
prescribed?
the only choice I would make if a person has irregular cycles and hirsutism.
Yeah.
Anti-androgen combined ciproterone acetate with estrogen and progesterone can also be used in our country because it's available. In some countries, it's not available. We don't use low-dose steroids. We don't use ketoconazole. We don't use GnRH antagonists for hirsutism. Insulin sensitizers, metformin has been told to reduce hirsutism, but the best choice in our guidelines is to use low-dose contraceptive pills. And we have to educate the patient that it will take at least 6 to 9 months.
Finastrides and flutamides with the evidence of hyperandrogenism.
We use finastride. Flutamide is highly hepatotoxic, so we don't use that drug at all. Finastride is used for women with androgenic alopecia.
Yeah.
But whenever we use finastride in a young sexually active woman, it's better to combine it with OC pills because it's an anti-androgen.
Yeah, anti-androgen. Also some 1 milligram, 5 milligram.
Yeah, so we use finastride only in that scenario where spironolactone again has to be combined with OC pills because spironolactone can cause withdrawal bleed and it can cause more irregularity of cycles. So in this scenario, particular case, OC pills is a good choice.
They say this fluorinethine comes on with face.
Yes,
available.
Ornithine decarboxylase inhibitor, we have Efflora cream, which we use only for mild hirsutism on upper lip and chin.
Only for the face, yeah.
Along with the face cream, it comes. That's what.
Yes. OC pills with drosperinone progesterone preparation is also useful.
Yes. Current OC pills are very safe to use. So many people are very apprehensive, especially the mothers or the parents. They're very, when we mention OC pills, we have to tell them that they're safe.
Yeah. So now when we talk so much in support of OCP, let us just see how it suppresses the secretion of LH and therefore it decreases the ovarian androgen production. And the estrogenic part there increases the SHBG and therefore reduces the free testosterone. Of course, progesterone in high dose and otherwise decrease the SHBG. So probably not for that role, but relatively less androgenic norethindrone, acetate, ethinidiol, and desogestrol and MPA have been used in the combination for OCP. Am I right, Anjali? Is that okay?
Yes,
yeah. And so now, just to have brushing up whether CPA, how does it do? It reduces the LH and therefore decreases the circulating androgens. Spironolactone has been discussed. It blocks the androgen receptor. Insulin sensitizers, we know. Flutamide, again, not so very favorable. Finastride is a alpha reductase inhibitor, so attacks the target areas. Analogs and antagonists for GnRH, not in this adolescent age group, definitely not favored, especially with the bone mineral density in question. And low-dose steroids periods are now out of the armamentarium, though they were discussed. And of course, we have talked about efflornithine.
Only for CAH. You
Yeah.
reserve that only for CAH.
Yeah. CAH is an entirely different. I think it will take another 1 hour if we talk about. So I just did not get it into the discussion. And so it is very important that we have an improved diagnostic accuracy, and there need to be only a very small overlap between underdiagnosis and overdiagnosis, which may always happen. And irregular menses, this Dr. Usha did discuss how we label them as irregular periods post-menarche, and then we have to label them as an hyperandrogenic state with the lab, or the severe acne by RNA hirsutism by this thing. And we know PCOS is not diagnosed by USD till 8 years post-menarche, and that is a dictum. So if for a general consensus, just as this mild hirsutism with no other signs of virilization and normal periods, we can take them as idiopathic, and I suppose idiopathic hirsutism does not need an treatment as such, and the mild to moderate hirsutism with no other signs of virilization in regular periods may give us a clue about the polycystic ovarian syndrome. So I think so your advice overall for this patient, Shanta?
Advice would be based on, again, our diagnosis. So if you've made a diagnosis of PCOS, well, I think we've already discussed everything, right from weight loss to exercise, to structured exercise, and dietary advice, and ensuring that she gets her periods at least every 3 months. And if the hirsutism again is mild, we can actually watch and see. But anyway, if you resort to giving her if you decided to give her progesterone to give for the endometrial shedding to give in order for her to get her periods every 3 months, and if she's also concerned about the hirsutism, well, yes, OCP would be a first choice. I would actually stick to OCP, something like overall L or something like that is what I would prefer, rather than giving her cyproterone acetate, diane, or drospirenol containing, because we should be concerned about giving giving a young girl like this anti-androgens for a very long time, because there is some concern about the effect of anti-androgens on the bone. I read an article, 1 or 2 articles on that, and therefore my first choice, definitely, as Dr. Anjali has mentioned, definitely OCP overall L would be my first choice. Yes. And what else? And if you're looking for insulin, resistance, if she's got acanthosis nigricans, or if she's got altered GTT, like she mentioned 75 grams 3R 2R GTT, if it is altered, or if she's got any increased weight. I don't think we right now the consensus to give metformin or insulin sensitizers for all those things. In fact, I wanted to ask Dr. Anjali, when would you think of prescribing metformin or insulin sensitizer? The indications precisely.
Yeah. Metformin is given in case the patient has impaired glucose tolerance. Impaired glucose tolerance. For hirsutism and anovulation, no. And if metformin as a weight loss medication is not a great medicine.
Yeah.
No, not to be okay.
No. So only if there is impaired fasting. Yes.
Or if she's got acanthosis nigricans, you definitely, because that's a marker of resistance.
For acanthosis, I would tell her first to try lifestyle. Definitely.
Okay. Then but along with goes hand in hand along with lifestyle.
Madam,
Dana, please go.
As Dr. Anjali said, when she comes to hirsutism, talk only about hirsutism in the first sitting.
Exactly.
Let us come under your fold, then you talk about weight loss. As Anjali Madam rightly pointed out, they are very, very sensitive about these small issues. I come with hirsutism, treat me. That is their attitude with young girls. To treat it, so over a period of time, you can gain her confidence, and after that, you can kind of discuss biochemical parameters with her, the own reports with her, and then she will understand all this had happened because of her little indulgence during her formative periods between 10 to 14 years.
And also one more point, what we grade our hirsutism as mild, moderate, severe. But for the patient, even that mild hirsutism will be very, very serious problem. So even one hair casts a shadow. That's a sentence mentioned in our textbooks.
Yeah.
We should take it seriously.
True that. So we move on with the management with what she comes, and then let us go ahead and see what else we have to discuss. A 17-year-old girl with age of menarche, 11 years, BMI 20, had fairly regular menses for 3 years. And now after 2 years of scanty irregular periods for the last 1 year, no periods at all and attributed to her stressful studies and exams. Her parents kept saying, we don't know, she doesn't even come out of the computers, and a slight heaviness in breast. So seeks management how to proceed, Dhana.
Yes. So,
no, something irregular. Think about. Yeah.
Yes.
Fairly regular earlier, then she had irregular for about 2 years, and now it has completely stopped. So what are we thinking and how do we proceed? Of course, we'll be doing all the tests and all usual for everything, but what is your,
what is it? Exaggerated premenstrual syndromes, like heaviness in breast doesn't go with irregular cycles generally. It rather goes with the regular cycles where you are supposed to, most of them are related to progesterone component of our menstrual cycle, and reassurance would be enough, and maybe placebo treatments like vitamin E tablets or evening primrose oil for 10 days in a cycle should be sufficient to take care of our tender breasts. But if irregular cycles is a major concern, you can still advise her to go get a withdrawal with just progesterone for 5 to 10 days in a month, rather than going for a full OC pills. Because she did have regular cycles before this 2 years, right? Just find out if she had been having a sedentary life.
Let us not take them for granted, and they all carry some contraceptive pills in their handbags. We have to, whenever there is an amenorrhea and a girl who is beyond puberty, I think directly, indirectly, with a side angle, whatever.
Madam, you said she is inside the computer room.
You know, joint studies living in, we don't know what is happening, but whatever. Let us not forget, because if we miss, then it's going to be difficult as well. So with a little bit of pinch of salt, but then we will have to really think about it. So her personal history, family, medical, because no mother will accept that her daughter has any issues. So that is beyond the point. But then, of course, we need to really take her into confidence and ask about. That's why the detailed history and, of course, the examination, abdomen, breast, whatever we can do. And then comes the investigations. So yes, the baseline labs are normal. Beta HCG for my, I don't do UPTs because then they get doubt. So beta HCG along with the blood test. After, of course, informing the mother, it's very hard nut to crack, but still. And hormonal profile, LHFSH slightly raised, and serum prolactin was 80 nanograms, and the repeat was 110, and USG pelvis was normal. So a little bit of working diagnosis came on with the hyperprolactinemia with secondary amenorrhea. Do you agree?
She need imaging of the brain, madam.
Why I'm coming to that. I'm coming to that.
First, thyroid profile, madam. Thyroid profile, madam.
Thyroid
Can I
profile.
think?
Thyroid profile.
I don't know, but you can have a picture like this with serum prolactin.
Isolated serum prolactin alone.
Why is the LHFSH raised?
LH was, no, the LH to FSH was raised, but there was only a mild elevation, but that apart, all the lab tests were normal. And this came staring, and otherwise, nothing else was there. Yes, Anjali, you wanted to say?
First thing I would ask is two things.
Yeah.
You said she's extremely stressed. Now, is she taking any medications for stress?
No, she said no, although we know
like
all we know all psychoactive drugs do rise to
and even PAN-D and all that, prokinetic drugs which they use for acidity can push up the prolactin.
Yeah.
Second question that I would ask is she having galactorrhea or does she have weight loss, severe weight loss?
She doesn't have, she doesn't give an history of weight loss. She say her mother said she doesn't even eat properly. And as far as galactorrhea was concerned, that was, she didn't complain. She didn't give a history. And when I checked, it was not there as well. But with this prolactin, generally, yes, we do find, but anyway, it was not. That's why probably she was feeling a little heavy with the breast. I don't know whether that kind of a picture comes on.
Now, high prolactin, if it is tumors. No, high prolactin.
I'm coming to that. I'm just wanting to know, is
the high prolactin, if it is bioactive, should have suppressed the gonadotropins.
Yeah.
Yeah, that's what
gonadotropins are
she has normal. We would think of we would think of bioinactive prolactin like macroprolactin.
Okay.
But so, here you say she is amenorrheic also.
Yeah, for the last 1 year, completely amenorrheic. Before that, she had only scanty periods for 2 years. And before that, she had regular periods. So now, So we know anterior pituitary secretes prolactin, just a gross idea. But now they say it is also being secreted from CNS, immune system, uterus, and breast. I don't know about this, but I have always known from the anterior pituitary and hypothalamus. Giving dopamine, we know, has an inhibitory control. This is the basic mechanism when we talk about prolactin, and the loss of inhibitory effect of dopamine comes on either with the interruption or obstruction of the portal venous system. And all these things can, on the both sides, we know can be stimulators, stress included, and of course all this. And as far as prolactin is concerned, if I'm right, early morning is a time when, because of the circadian rhythm, I think that's a time fasting prolactin has to be tested, isn't it? And also we should not do a venipuncture with the pressure on. That's what they say. Is it, Anjali?
One more point. The person from whom nowadays people go for home collection.
Yeah.
So many times patients say they just wake up from bed. When the man comes to collect, they ring the bell, they just wake up from sleep and give. So the criteria, what we say is they should be awake for at least 2 hours.
2 hours.
If they're just waking up from sleep and giving the sample, their values can be elevated.
Yeah.
Immediately after the breast examination, also, if we take prolactin, it will increase the stimulation.
Because you have already stimulated the oxygen. So anyway, we know this is just to complete the list that all of them can be stimulators, and we need to keep them in mind with before we really brand them as a hyperprolactinemic girl. Now, prolactin also has a lactotrophic effect, we know, and regulatory effect on the gonadal function, and inhibition of GnRH excretion and secretion of LHFSH is also inhibited. And of course, now a big role is coming on immune system, adipose tissue, and insulin secretion.
Dr. Vijay, just 1 minute.
Yeah, please.
This is what we said. See, this is what even I mentioned, and I think the endocrine Dr. Satya also said. Inhibition of GnRH, actually, you will have low LH and FSH. This is what we said. But your patient, you mentioned that LH.
The ratio was more. LH to FSH ratio was higher. LH was higher. And so the pathological causes, we know all these causes can be there. We will run through for short of time because all of them can cause, but the most common, or probably in this age group, pituitary tumors, we need to keep in mind prolactinomas, and those we are incidentally discovered incidentalomas. So anything on this, Anjali? Anything you want to add on, Anjali or Dana? Or
yeah, usually prolactin, which is elevated due to a prolactinoma, is seen in much higher levels, more than 200, more than 100.
More than 100.
But I've seen even 1,000, 500.
But sometimes in macroprolactinomas, we get falsely low values. So we should always ask for prolactin in dilution at that time. Suppose a value is given as more than 200, then we would think of prolactinoma as the first possibility. Here, I would first look at the LHFSH value. Now, because here the history is not fully like, is it, so if the prolactin is high, then we have to definitely image to see what is happening in the pituitary.
Yeah, I'm coming to that. Yeah. Any prolactin, obviously, and this is again the hyperprolactinemia, which can come on it, all these group of medications and antidepressants, as Anjali that time asked me whether she is on any antidepressants. We know these antipsychotics do cause, and many of them are on these drugs already. Some anti-epileptics on antiepileptics as well are going to cause. So it's very, very important to take a detailed medical history. And of course, prolactinomas, because of their site, cause problems with the visual acuities and peripheral visions. And of course, headaches can come on. They also have a role on the skeletal abnormalities. Yes, Shanta? On the,
no, why skeletal abnormalities?
They come because of the osteopenic effect, osteoporotic effect, which comes. Yeah.
Hypoestrogenemia can cause bone loss. Okay. Yeah.
Yeah, bone loss is there, and it can present as primary and secondary amenorrhea. Abnormal uterine bleeding, delayed puberty, we all heard that, and of course the infertility and galactorrhea, which was really not very evident here. So all these can come on with the hyperprolactinemia. So let us just think what we are, OCPs, okay. So the radiological diagnosis probably is a very important diagnostic tool here. Dhana, are you there? Dhana
Yes,
Lakshmi?
ma'am. Yes, ma'am. Yes, ma'am.
I just want you to comment on this. X-ray skull causing pituitary fossa.
So generally these days we are going for CT scan, ma'am.
Yeah.
CT.
We go for MRI. Directly we go for
CT,
MRI.
CT exposure.
Or MRI. X-ray skull, as a bookish teaching, we teach them, but otherwise, the patient can afford MRI or at least a CT.
For pituitary imaging, we should not do CT. We should only resort to MRI with gadolinium contrast.
Gadolinium, yeah.
Contrast. A CT scan does not reveal the pituitary because if it's a microadenoma, we have to do a post-contrast enhancement. We don't
So X-ray skull, of course, we used to do earlier, now not pituitary fossa showing anterior clinoid process elevation or doubling of floor of the pituitary and all. But we know the X-rays are not really done properly. We know the cone down views were done. But now I just put it because we should understand that CT scan and MRI need to be done as well. Now, serum prolactin more than 100. They say if it is there, then one test is enough, or else 2 tests need to be done. And if it is more than 500, probably you're thinking of macroprolactinoma. And if 10 times macroadenoma, less than 200, could be just drug induced. Is that okay? Anjali, you want to add on to this?
No, I think
Or
above
subtract
100.
something?
Yeah, sometimes even non-functioning pituitary tumors can cause high prolactin because of stalk effect. Anything that pushes onto the stalk will cause elevation. So above 200 is indicative of prolactin secreting tumor. Above 100 could be a non-functioning pituitary tumor. So either way, we have to do an imaging.
So now, so the management, we will quickly just talk about targets. Pramila, Mohana.
Madam, yes.
Our targets are here.
Can we, I want to ask Dr. Anjali ma'am, see, if the prolactin level is less than 100 and if you have ruled out all the drug intake and all, can we start her directly on the gabapentin and give her 6 weeks of gabapentin, repeat the prolactin? And because if directly if we say MRI brain for her and the patient and the attendants, they get apprehensive.
Yeah, so I didn't say MRI for a value of say 55 to 65 because 20% of women with PCOS may have mild hyperprolactinemia. We are talking about values above 100. The thing is, we can't miss a tumor.
Yes, madam.
All we can say is that no. So what we have to explain to the patient is your values are above 100. And if the patient gives, we have to ask for history of headaches, visual disturbances, all those history is important. So the thing is, as a physician, we say above 100, we are in, it's when you start treatment, gabapentin, and if the patient happens to have a microadenoma, it might disappear. So follow-up imaging after starting treatment may not reveal anything.
No, but when we tell them that we are trying to look into the pituitary, we know you have a very good brain. We are not really trying to
no, that is all. Because what we try to convince them is,
just like how we look for thyroid here, we are trying to locate. It just happens that pituitary is inside in the cranium, close to the brain. That's
but
all.
For a mild hyperprolactinemia, we will not do imaging.
We will need
As you said, we will treat with a
up
short course of gabapentin.
maybe.
Give a short course, see how the cycles come, withdraw it after some time, and again reassess if the cycles become irregular again, and see if it is repeatedly coming. But mild to moderate and all, we don't need to do imaging.
So the targets is resolution of the prolactin excess, normalization of the pubertal development, sufficient restoration of the gonadal function, shrinkage of the pituitary tumor, maintenance of bone mass, and preservation of the future fertility.
I think microadenomas we are seeing lots.
Sorry to interrupt, madam. Madam, can we finish with this case alone, ma'am?
That's what I said. Panel cannot go on with 4.
Yeah, we will finish
after the 4 talks. It's very tough to not really do good justice to the panelists. For me, it doesn't matter. Anyway, dopamine agonists and semi-synthetic bromocriptine 2.5 to 15 milligrams slowly increased, and of course gabapentin we are all very familiar. I'm not going to go into the details of this. And so follow-up, how do you do the follow-up for this, Anjali?
If it's a prolactinoma, we start them on gabapentin and reassess the prolactin after 6 to 8 weeks. and then phase down the dosing and follow them up every 3 months initially. And the repeat imaging is not indicated if it's a microadenoma, because the only thing is we have to, when do we consider stopping the therapy? If it's a documented microadenoma, we continue the therapy and maintain the prolactin and watch how the cycles come. And if the prolactin remains low normal on the minimal dose, then we can consider withdrawal. But generally, they require a little longer therapy, which we explain to the patient in the beginning itself.
Okay, so I think I just had one more case, because other case I took it off, seeing the time and the flow. But this again, if they don't want it, we will just close it here. This was about thyroid, which I thought could be a quick discussion because with Anjali. But anyway, maybe we can do it later. Anyway, I think 4 talks and 1 panel is a little too much for 2 hours. So either you keep 2 talks and 1 panel, or you just keep 4 talks. That would be my humble suggestion, because it's not right, especially panels, we cannot cut short. And the whole idea of getting the thoughts from experts goes off. And we don't have anybody, anyway, a lot of people have gone to dinner and sleep. So we close down here. And thank you very much for the opportunity. And I really want to thank you, Anjali, Mona Pramila, Dana, and of course, my very good friend Shanta Bhaskar. We should have had a little more inputs, but it's okay. Thank you so much.
Thank you, Dr. Mala.
It was an excellent panel, actually. Well moderated by Dr. Vijay Lakshmi, and of course, ably assisted by the erudite panelists, Dr. Anjali, Dr. Dana, Dr. Mohana Pramila, and Dr. Shanta. And it was indeed very useful. The first one, there was a question in the chat box. So they were asking about the, not about this panel actually, about the precautious puberty. So we start evaluating for precautious puberty when there are physiological, when there are pubertal changes at the age of 8 for a female and at the age of 9 for a male. So that means tilaki, all that. So they were talking more about, the question was about menarche and all that. Menarche is a final event. So when these changes take place itself, we have to start evaluating. And this ultrasound usually for a PCOS is advocated only after, at the gynecological age of 8 years. So 8 years after menarche.
Yeah, we spoke about it.
We advocate
we told about it.
Ultrasound. And there was a talk about breast handling and all that. Earlier, we used to talk a lot about breast handling affecting prolactin. Now we have a lot of reports where even after mammography, even after breast ultrasound examination, it doesn't cause that much increase. Only if it is marked, then probably we have to take. And I think
India madam has
we have
left,
to rule out TB also. TB endometritis is not an uncommon thing in our this thing. Scanty periods, then going in for amenorrhea. Of course, prolactin all was there, but then history-wise, initially.
See, I was trying to pinpoint more of endocrinal issues today.
No, I understand.
We were not really trying to analyze the entire scenario. That's why I just gave tips so that we could discuss more on the endocrinology, because that was the focus today, endocrinology in adolescents. Otherwise, we know lots of things can be brought into differential diagnosis. And I was trying to pitch in more of inputs from the endocrinologists and all my esteemed panelists who are really well learned and this thing. Thank you, Shanti, and I think Cynthia madam has left. So thank you.
Thank Dr. Jairani, Dr. Mala, and Dr. Kundavi for having given us an opportunity to join in this session. It was really a very nice academic.
I think one day we will have only panel.
Yeah, thank you so much, Vijay Lakshmi madam. That was an excellent panel. Sorry, really, we are running short of time. That
in fact, I was willing to even postpone the whole panel.
Yeah, but then we cannot do justice, madam, if you have to take only few topics and say adolescent endocrinology. So
no. But 2 hours is
We
not
had
enough.
to have 2 sessions, madam, but then
2 hours and then introductions, then all those CVs, everything takes time. So I think we have to really be on
we'll
time.
keep one more session, madam, on this.
Okay, we will talk more and we will
so
call
much.
the same panelists at that time. Thank you very much.
Thank you, Shanti madam, and all our esteemed panelists also. Shanta madam, Anjali madam.
Same expert also. Okay. Thank you, Mala. Thanks. That was wonderful.
Thank you.
So with this, we like to, we come to the end of the entire webinar, and this was in fact an excellent session. So late in the night, still we have quite a lot of people logged in. In fact, until now, there were almost 60 here. So that shows how interesting and informative it was for all of them. So I would like to thank all the faculty for their contributions. In fact, everyone had done so much of justice, and it was such a learning experience with so much of information and sharing of knowledge. I would also like to thank Shield Pharma and Chitrakala for helping us with this academic venture. And also thank Jairani madam and Kundavi for giving me this opportunity. In fact, it's an entirely different role for me. That is, endocrinology committee is something which I never thought I would be able to take it up, but then I had to do it. So finally, my sincere thanks to all our delegates who've been waiting until so late in the night to attend this meeting. So with this, we come to the end of the session, and thank you all so much. So
thank you.
Again,
Thank
with
you.
another webinar, maybe next would be on infertility is what I was thinking. And then we'll decide and get back to you also. Thank you, everyone.
Thank you.
Thank you very much. Thank you.
Thank you. Bye, Shanta. See you sometime.
Thank you.
Bye, all. Bye.